Good morning, everyone, and welcome to today's invitation-only workshop on advances in uterine fibroid treatment with focused ultrasound, hosted by the Focused Ultrasound Foundation. I recognize and appreciate that many of you have sacrificed either waking up early or staying up late to participate today, but we were committed to convening the international community for this workshop. My name is Suzanne LeBlanc, and I'm the Director of Clinical Relationships at the Focused Ultrasound Foundation. We are pleased to also acknowledge Chongqing HIFU as a co-sponsor of this event and extend our gratitude for their support in helping to bring this important conversation to life. The workshop has been thoughtfully organized by a dedicated steering committee who have worked together to set the agenda for this workshop, so I would like to personally thank them. It's Dr. Loz Gnorin, Martin Boomsma, Peggy Ganuni, Selva Supramanian, and Rosie Zing. I would also like to express our deep appreciation to Dr. Ebby Stewart, whose leadership and early support for focused ultrasound over the years has been instrumental in advancing the field. Her participation today brings valuable perspectives and continued inspiration, and her recent article on uterine fibroids published in the New England Journal of Medicine in 2024 is a perfect segue into the topic today. Now, this workshop is centered around 4 burning questions, each designed to spark meaningful discussion and identify clear steps to advance the field, and you see them on the screen here. The insights and perspectives shared today will contribute to the development of a comprehensive roadmap to guide future research, clinical practices, and also spur innovation in the treatment of uterine fibroids using focused ultrasound. While participating in this webinar, please refer to the program book that was distributed, which contains important information for today, including the 4 burning questions, biographies for the moderators and panelists, and the list of pre-reading material, and also importantly, a comprehensive set of tables detailing the state of the field comparing focused ultrasound to other minimally invasive procedures, which was graciously prepared by Dr. Loz Gnorin, a member of our steering committee. We are honored to be joined by an outstanding group of moderators and panelists, truly leaders in the field all over the world, each bringing a wealth of expertise and experience. We encourage open and candid dialogue throughout the sessions and invite all attendees to actively participate by submitting questions using the Q&A feature located at the bottom of your Zoom screen. These questions will be relayed to our panelists to help enrich the discussion. Of note, we will keep your cameras and microphones off if you are not a live moderator or panelist for that session. When it's time for your panel, we will activate your camera, and please watch for the activate camera box to accept. If anyone has questions during the workshop or have any technical difficulties, please send a message in the chat function, or you can text Joe Rice at 434-996-8890. Now, each of the 4 sessions will open with a brief overview by a moderator from our steering committee, followed by a panel discussion, during which each panelist will introduce themselves before engaging in the conversation. We are grateful for your participation and look forward to this exchange. Now, for a little background material before we officially start session 1, I want to emphasize that we are excited about the growth and innovation in this space. Between existing companies that have been improving their focused ultrasound machines to meet the needs of patients and providers, and new companies, there are about 8 companies overall in the space treating fibroids. 3 are MRI-guided and 5 are ultrasound-guided. 2 out of the 5 ultrasound-guided machines actually treat with the patient in the supine position, and this is going to enter in discussion on how to best treat these patients. From our 2024 Focused Ultrasound Foundation State of the Field report, nearly 50% of the now almost 1 million patients treated to date with focused ultrasound were for women's health issues, and most of these were for fibroid treatments. So these numbers support the importance of moving this clinical application for fibroids forward even more to treat the tens of millions of other women suffering from fibroids. Now, I would like to formally introduce Dr. Ebby Stewart, who will provide us with an introduction to session 1. Dr. Stewart is professor of obstetrics and gynecology in the Division of Reproductive Endocrinology at the Mayo Clinic. She has literally published hundreds of articles on fibroid treatments. I remember back in the late 2000s listening to her present data about uterine fibroids and her thoughts on where FUS may potentially fit into the armamentarium of treatment options for patients. She was instrumental in conducting numerous trials that included FUS, comparing it to other treatment options and accumulating real-world data. The first study was an RCT comparing MR FUS with UAE. She has been absolutely instrumental in helping FUS find a major place in the ACR appropriateness criteria. So Dr. Stewart, thank you for taking the time to be with us today. and we very much look forward to your participation. We're already ahead of schedule for more interaction in our panel, so the floor is yours.
Thank you so much for such a kind introduction, and thank you for the organizers. I think that this is an important and timely topic. And I think at the end of my brief introduction, you will see that I earned all of my gray hairs naturally, because this has been a process that has literally taken a quarter of a century. That it was in late 1999 and early 2000 that we began discussions about clinical trials to support focused ultrasound for fibroids. And for those of you who are coming to this discussion from the broader perspective of treatments for neurologic disease or other diseases, that those were not even on the table at that time. That we started our clinical trial in early 2000, and in the age of worrying about Y2K, that seems like very distant history. We had our first two publications in 2003, which really talked about the feasibility trial that we did prior to hysterectomy to show that we could safely target the uterus through the anterior abdominal wall. And it was in 2006 that we published the results of our pivotal trial. And I can tell you that it took 6 submissions, including one where the journal editor specifically instructed us to rewrite it in this particular way, and then still rejected it. And I think finding a home in a journal for innovative therapies that are widely read is likely still a problem. So in 2006, we published our data. In 2007, the FDA gave approval for the first device. And Suzanne alluded to the RCT that we performed. We got the funding for that in 2016. So again, that it's literally been 25 years since we started this process, and we really are not where I feel we should be. And I think there are multiple barriers, from the disease itself to the availability of time, particularly for MR-guided procedures, to the political landscape that sometimes undervalues women's health and undervalues quality of life compared to diseases that cause mortality. So once again, I want to thank everybody for the invitation and look forward to today's discussion. Can we go on to the next slide, please? So the first session will take on the burning question of what is the safety and efficacy of high-intensity focused ultrasound compared to other standard of care procedures for fibroids. Next slide. So here's a view of a graph of symptom reduction. The standard measure for measuring symptom severity, or SSS, is the UFS-QOL subscale that Jim Spies developed, and it is normalized to a 100-point scale. And so you see from 0 to 100 on the y-axis, and then you see months of treatment on the x-axis. And hopefully the colors are coming through to everyone in the same way, but I see that ultrasound-guided focused ultrasound is the light blue line. The orange line is MR-guided focused ultrasound. The gray line is uterine artery embolization. The yellow line is radiofrequency ablation, and then the darker blue line is myomectomy, so that you can see that symptom reduction with these two therapies is at least equivalent to those of other modalities that are much more widely used. Next slide, please. The other scale in the UFS-QOL is the health-related quality of life, which has 6 subscales, and this shows the total results. And again, it's in a reciprocal relationship to the symptom severity score. The higher the symptom severity score, the more severe the symptoms, the lower the HRQL score, the better the quality of life. And again, you see that that the ultrasound-guided focused ultrasound and the orange bar looking at MRG-FUS appear to give you very good improvement in quality of life and well within the range of the other treatment modalities. Next slide. Reintervention rate is an issue now. One of the things that needs to be kept in mind is that focused ultrasound, like myomectomy and like radiofrequency ablation, is a fibroid-specific intervention. So each fibroid needs to be targeted individually. This makes a difference because not every woman presents with a single fibroid that's 5 centimeters, and that the woman who has 8 fibroids will likely have some disease undertreated or non-treated with a lot of these treatments. And this is in contrast to uterine artery embolization, which does target most fibroids, clearly the ones that are drawing their blood supply from someplace other than the uterine artery are not impacted. But again, this is a much rarer occurrence. So one of the real issues with fibroid care is that even if all of the disease is treated perfectly, the fact is the uterus can make new fibroids, and the data suggests that the reformation rate is higher when you have more fibroids. I think the thing that's not been as well appreciated is actually the overall reintervention rate in a general population is relatively low. And we have some data coming out of long-term follow-up of the Compare UF registry that shows 3/4 of women treated in that trial had intervention-free survival and didn't need another fibroid treatment with a variety of modalities. So again, there are women that need additional retreatment, and there are multiple factors leading to this. It could be inadequate treatment of disease. It could be inadequate selection of the fibroids to treat. It could be a mismatch of expectations between patients and providers in terms of what specific therapies accomplish. And finally, it can be related to other present diseases. So if you successfully treat all of the fibroids, but the patient has undiagnosed endometriosis or undiagnosed adenomyosis, that those can be confounders as well. So it's a complicated process. But again, you see that the curves are very similar, and particularly for less than 48 months, the intervention rates are low. Next slide, please. So again, if we look at safety profiles, I think that that's where this technology really has a major advantage that isn't even well understood among gynecologists. That I think that because gynecologists deal with surgical procedures and often accept the complications of surgical procedures, such as infection and bleeding, as the background, that procedures that don't have these complications are not as appreciated. Again, I think you see that in some of the early randomized trials of, say, surgery versus uterine artery embolization, where return to the emergency room was counted as a complication, despite the fact that the women who had myomectomy were in the hospital for 5 days, so they wouldn't be returning. They would have been there the whole time. That if you had an issue that needed evaluation, that counted as a complication in the UAE group, and the requirement for inpatient care did not. So I think dissecting out the advantages of a procedure that can be done in an ambulatory environment with minimal or no anesthesia, that doesn't carry with it a bleeding risk in a woman who is already anemic at baseline, is, I think, underappreciated in some of these numbers. So as an overview, happy to address other issues, but I think it posits some questions for the rest of the morning.
Thank you so much, Dr. Stewart. That was a fabulous introduction to this session. So we welcome this very esteemed group of panelists, and I would not do them justice, Dr. Stewart. I think we should let them introduce themselves and let them know why they have a passion for being here, and start to address some of the answers to the burning questions. What do you think, Dr. Stewart?
Sounds good.
Great.
Jay, you want to start us off?
Sure. So I'm Jay Berman from Wayne State University. I've been involved in fibroid treatment for a long time, starting with really with endometrial ablation and then myoma resection. And I was lucky enough to be a principal investigator at the local site for both Acessa and Sonata. And I've followed those two procedures for a long time. Acessa was approved in 2012, which seems like a long time ago. I also had the opportunity to consult with both companies in trying to get coverage, which was a very interesting process. And you showed some of those things in your slides of how well this works, but the insurance companies were interested in long-term data, and obviously the studies only went out to 3 years. And it was one of the issues of trying to obtain good coverage for both of these procedures. And I agree with you that the complications are overblown. Most of them are minor laparoscopic or hysteroscopic type of complications that we see all the time that are minor inconveniences to most patients. The major complications, few and far between. And the comparison to the myomectomy as the gold standard, which has significant recurrence rates, probably higher than what you showed in the graph for these minimally invasive procedures, is neglected when you're discussing this with an insurance company. So I'm happy to participate in improving the care for our patients with fibroids. It's desperately needed in women's health, and hopefully we will continue to move this forward.
Thanks for a nice overview, Jay. Gina Hesley, you want to give us an introduction to your background?
Sure. So I've been at Mayo Clinic and working with the focused ultrasound device, the Exablate, since about 2001. We were fortunate to be involved in the trials prior to the FDA approval, and I'm very, privileged to be able to work with Dr. Stewart and many of her colleagues who refer patients to us and collaborate on selection of patients as well as follow-up of those patients. We're currently still using the Exablate device. As many know, that device has now reached an end-of-life status. We're fortunate to be able to upgrade to extend it to 2028. And we're also working on an IDE to potentially utilize the Sonaleave device in our practice. And I'm very excited too about the future of ultrasound-guided HIFU. So something I look forward to hearing more about today. And I've been excited to learn more from Rosie over the time. So,
great. Dr. Lee?
Okay. It's an honor to meet you. I am Dr. Jason Lee from South Korea. I have been treated HIFU 2010, and I have a treatment cases over 3,000. I use ultrasound-guided HIFU treatment, HIFU, and I have 10 papers with include 7 SGI grade level, and I'm really appreciate if my experience might help you. Okay.
Thank you. And Dr. Burton-Kate?
Yes, hello, I'm Miranda van 't Veer. I'm a radiologist and working in the Isla Hospital in the Netherlands. I'm from the same group as Martijn Boomsma and Loes Knorren. They're also here in the session this afternoon. For me, it's afternoon. For others, it's other times. I'm working quite a years now with the HIFU. It's still in research in the Netherlands because it's not insured care in the Netherlands. So we hope with the research we do, it will be insured care in the Netherlands, so we can expand the HIFU treatment in the Netherlands.
So what is the safety and efficacy of high-intensity focused ultrasound compared to other standards of care? I think Jay alluded to safety before, but maybe we can have each of the panelists talk from their perspective for a minute about what they feel is the key safety issues that need to be solved, publicized, disseminated. What is the barrier to these issues?
All right. So thank you to the panelists. It's interesting. We have 2 gynecologists, 2 radiologists, some people that perform MRI-guided focused ultrasound, ultrasound-guided focused ultrasound, and of course, Dr. Berman doing the other procedures. But in terms of safety and what you feel is the most important safety consideration to tell your patients and to think about while you're doing the procedure, I'd love to hear from the MR-guided focused ultrasound people first. So Gina, maybe you could go first.
Sure. So the main one, of course, I worry about are the most serious complications. So for that, I would consider bowel injury is kind of the thing I'm always on top of, and making sure that we're getting a nice, safe beam path. So that's kind of the primary focus. However, we also take a lot of consideration when we select patients, looking at their overall intra-abdominal wall thickness and the brightness intensity of the fibroids on T2 weighted images. As we know, the more energy we put in, the more likely they are to have even a minor complication of something like a little bit of abdominal wall edema, potentially having some abdominal wall musculature, having some edema as well, depending on, again, on how much energy. We certainly pay attention to surgical scars, but I think with being very closely attentive to where the location is and sending the beam path through in different ways, we can often mitigate issues regarding the presence of cesarean scars and even midline abdominal scars.
Yes.
Sharing that. If everyone else could mute their microphone, if they're not speaking, that would be fantastic. So thank you. But Gina, thank you for sharing the fact that like bowel injury was number 1. Like that's the first thing you mentioned, right? That we just want to make sure we avoid bowel injury. Brenda, how about you?
Yes, of course, the bowels are very important. And the skin heat. Now with the modern devices, you have more, you can better cool the skin. So that isn't that a problem anymore. But of course, when there are scars, that will still give a problem. We always check in front if there are scars. With minor scars, it will go. But if there are big scars, then we have problems with heat accumulation there. So we see that. So that is where we look for when we start. Yeah, and also for the sedation of the patient, you have to, we do it not with complete sedation, but we give some pain and also give some medication. They will sleep a little bit, but you have to be sure that they won't get too much medication, that they will instruct you good if they feel pain or something. So that's also you have to be aware of very well during the treatment.
Interesting. Thank you. Thank you. And really, Jay, would you share your safety concerns?
I'm sorry?
No, thank you for that. I was wondering if Dr. Jae-Sung Ling could go next and talk about his safety concerns.
Yeah, thank you. I am the gynecologist for 23 years and have been treating HIFU, ultrasound-guided HIFU for 16 years. I have experienced myomectomy, hysterectomy, laparoscopy, and open laparotomy, and HIFU and a little RF case. I think in aspect of safety of HIFU, as mentioned before, HIFU has acceptable side effect and is considered reasonable safe. Since there are many cases of HIFU, so I think the complications will be more diverse. Currently, as a gynecologist perspective for efficacy of HIFU, now currently exclude hysterectomy. Myomectomy is the most radical treatment for uterine fibroid. Most gynecologists may agree this opinion. In order to compare efficacy of HIFU with other standard procedure, I think the myomectomy should be considered as an absolute reference point. If we compare the efficacy of each procedure based on myomectomy, we can easily know how much therapeutic effect each treatment has. In my experience, although not all fibroids are suitable to HIFU treatment, but HIFU have a very broad therapeutic window, like myomectomy. HIFU can successfully treat various size, various number, various type, and also combined case with adenomyosis. HIFU can make a complete ablation of a whole region than other procedure. So we can make it possible to treat various difficult cases successfully. Sometimes I think HIFU is better than myomectomy in many cases. I will share you following three cases. I prepared 3 example case. Maybe most gynecologists want to do hysterectomy. The first case is multiple fibroid. There are more than 20 fibroid in uterus, and the fibroid size was varied. I had one session of HIFU treatment for this case. Treatment time was 84 minutes. After HIFU, over 90% of fibroid in uterus were non-perfusion volume enhanced in MRI imaging. Like this case, cavitation effect of HIFU is very important. And the second case is also multiple fibroid with huge uterus. Uterine fibroid size is 7.665 centimeter size. Uterus was enlarged up to 14 centimeter length. I treated over 90% of uterine fibroid on a whole region in one session of HIFU. Treatment time is 100 minutes. T1 weighted MRI image shows well-treated state. This patient, 15 months later, uterus size was decreased to 7 centimeter, and all previous treated myoma were non-enhanced state by MRI images. And the third case is 6 submucosal fibroid with diffuse adenomyosis on fundus. Especially, most gynecologists like to do hysterectomy to adenomyosis. She had 2 times myomectomy in past history. Treatment time is 2 hours. I think HIFU treatment can be good modality for like this case. After 9 months later, myoma has disappeared and uterus size was normalized. Menorrhagia and dysmenorrhea symptom was totally disappeared. She could preserve her uterus. I think HIFU can make it possible to treat many difficult cases successfully because as you know, HIFU use ultrasound energy, so it's easier to deliver the energy at exact location and to provide exact desired amount of energy at the location. However, in other standard procedure, it's somewhat difficult to deliver energy at exact location. They have already limited direct access to the location. By HIFU, we can directly approach the exact location and the exact energy in the location.
Well, thank you so much for showing us those cases. And I think, what's so important is, number one, you significantly treat all of the fibroids, which is amazing. And from my knowledge of reading your literature, as well as the existing literature, the incidence of bowel injury as our primary safety concern is really low, like probably less than 0.1% even. I mean, it's low. So Dr. Berman, I would like to hear your perspectives as a surgeon, how we consider, and you can hear, terrified that bowel injury is our primary safety concern. It happens very, very, very infrequently. And as a surgeon, compared to the procedures that you tend to do more often, can you help us put it in perspective on how we think of this safety issue with focused ultrasound compared to other procedures?
Yeah, I think for radiofrequency ablation, I would divide the complications into immediate surgically related complications, mostly related to anesthesia and Foley catheter and that type of injury, as well as laparoscopic access. Many of the patients have had previous surgery, cesarean sections, myomectomy, whatever. So those are few and far between, and certainly no higher than you would expect in any laparoscopic procedure. Direct injury to the bowel or large blood vessels is certainly possible, although the literature has few numbers of that. In the clinical trial in the Assessa, there was one superficial injury from manipulation to the sigmoid colon that required a couple of sutures in the serosa. There was one postoperative infection related to early intercourse and sexually transmitted infection with a new partner. There have been post-approval several cases of infection in the uterus requiring subsequent hysterectomy. And there also are and you also see this in sonatas, you see passage of submucous myoma, prolonged discharge related to coagulative necrosis of those fibroids, type 1 and type 2 myomas. So overall, I think this is, a comparable to myomectomy, and I think in the same vein as the HIFU complications, although you don't have the anesthetic and the immediate puncture of organs, which thankfully has not really been reported in the radio frequency literature for Acessa and Sonata.
Thank you. Dr. Stewart?
Yeah, so I have some questions of my own, but I wanted to go back to the issue that both Dr. Berman and Dr. Lee raised about expelling the necrotic fibroid vaginally. Dr. Lee said the fibroid disappeared, which I presume means was expelled vaginally. But I think I'd like to hear the panelists say, how do you deal with this? I know in the early days, it was a crisis that people would show up in the emergency room. People wouldn't know what to do. Do people tend to prospectively schedule women for hysteroscopic resection when there's been focused ultrasound treatment? How do they prepare the patient so it doesn't become a crisis? How do we educate our referring providers? So maybe we can start with Dr. Lee and Dr. Berman on that issue, because again, I think that many people are still hesitant to treat intracavitary fibroids because of that issue. So Dr. Lee?
If we patient selection, we have to good patient selection, especially submucosal fibroid or intramural fibroid. I recommend the HIFU treatment, but the huge subserosal fibroid or myomatosis or the size is over umbilicus level is I don't recommend to HIFU to patient. Usually, submucosal fibroid and intramural fibroid is in near the muscle layer is separate near the intestine or near dangerous tissue from the dangerous tissue. So if we can control the power and the focus area is exactly focused area. The nearest the around the tissue is enough, safe enough. Okay.
But it sounds like in the case you presented a few minutes ago, there was a big submucosal fibroid that was treated, and you said it disappeared. How did it disappear? How did you instruct the patient to be aware of that? And how do you, particularly if the patient is going back to a local provider who may not have expert knowledge about focused ultrasound, how do you prepare her local gynecologist for the disappearance of that submucosal fibroid?
I think the submucosal fibroid is a reduction rate is 90% within 1 year, and maybe a small residual region can be preserved, but its necrotic region don't cause of bleeding. Any other problem.
So can you tell us what happened with this patient? Did she present to her emergency room? Had she been prepared? How do you set the patient up for success?
I told the patient to follow up every 3 months follow up to me, and I check the ultrasound finding and preventing infection for submucosal fibroid. The infection of submucosal fibroid is rarely occur, but we control the infection. The reduction rate is more higher, but for 2 or 3 weeks, she had a mild fever and discharge, but there have no critical complication.
Mm-hmm. And what happened when she presented with fever and discharge? Did she undergo a surgical procedure, or was she just...
No surgical procedure, only antibiotic and anti-inflammatory agent. If we needed direct current and direct dilatation and curettage is needed, some cases.
Okay. So, Dr. Berman, I'm sure you've dealt with this complication before. Can you tell me how you deal with it and how you set patients up to succeed and not get into trouble at an outside facility?
Sure. First of all, I think the type 0 and the type 1 fibroids are mostly resected prior to the radiofrequency ablation. And in my practice, usually not at the same time. We also use prophylactic antibiotics on all the patients for radiofrequency ablation procedures. And those that have type 2 fibroids, we prep the patients with information about them seeing discharge, and that might go on for several weeks, and actually sometimes a little bit longer depending on the size of the fibroid. I think that's very important. We also talk to the patients if they have to be seen. We of course prefer, if they're close by, to come to our hospital as opposed to one closer to where they live. We also tell them that they should try to avoid having instrumentation. Because in the clinical trial, there was a perforation that happened at an outside institution. The uterus is somewhat boggy and soft for several weeks after extensive treatment, which I don't know if you see the same thing with HIFU. Unfortunately, we haven't had a machine anywhere near our city for a long time. It's definitely been a problem. So I think preparation for the patients is very important. Intramural fibroids seem to shrink quite a bit more. The type 3, 4, and maybe 5 tend to shrink more than type 2 and type 6. So we can set those expectations prior to the procedure, and I think it's important for the patient to understand that before their procedure.
Nice. Dr. Hesley, I know you've dealt with submucosal fibroids. How do you approach them to have things go smoothly for the patient and the referring providers?
Yeah, so certainly over time we've learned and have counseled patients more so, and based on the location of them, counsel them about what they can expect, and then signs and symptoms to sort of watch out for, and to connect back to our coordinators. And then also we, at that point in time, if we are concerned, we certainly talk our collaborating providers to decide when we might need to bring a patient in versus when they may need to be seen locally. We do see a lot of patients who are not from our region. So we do spend a lot of time with the counseling up front, as well as maintaining communication after they leave, to ensure that they get managed in a less likely to be an operative way and more likely to be managed based on their symptoms, just to watch for signs and symptoms of infection.
So would you generally treat a type 0 or type 1 submucosal fibroid? Or Dr. Berman said he tended to resect it before RF ablation. Is that your approach, or do you often target that one as well and watch patients carefully?
Yeah, so sort of depends on the size, and that's oftentimes a collaborative discussion with the GYN who's involved with a patient to kind of see what would be best up front, depending on the size of that fibroid. Some of the smaller ones may get resected up front, and then we may treat the remaining fibroids in a patient who may have multiple fibroids. So it kind of depends on the case a little bit, but we do treat fibroids certainly that have an intracavitary component, and some of them that are super tiny, we may choose to just go ahead and treat those at the time, so that they don't have to go a second type procedure.
Thanks. And Dr. Burton, Kate, anything you want to add to this discussion then?
Well, we do it in research. So we have type 0 myomas. When they're small, the gynecologist remove them up front. And we did not have any experience with myomas that were having birth. So we don't have experienced that yet in our hospital.
Thank you. So I'd like to kind of go back to the early 2000s, and one of the key debates that often occurred at focused ultrasound meetings was whether MR thermometry was an essential safety feature that does understanding the temperature of the targeted tissue really contribute to the safety, or as the instrumentation has evolved, is that less of a pressing issue? Who would like to start us on that topic?
I can speak to the MR side of it. I'm very interested to hear from the ultrasound perspective, as somebody who has a very strong practice in regular diagnostic as well as procedural ultrasound. But on the MR side of things, certainly the thermometry has been one of the big selling features for safety to the patients as well. They've been very reassured by the fact that we're able to view inside and see exactly where that energy is being delivered. As a provider, being able to know that the temperature is rising and the location I can see, and I can see how much it is, so that I can tweak it to make it as comfortable for the patient as well as effective as possible. So it has been something that we've relied on for feeling like we're, being able to deliver an effective procedure, but also being able to maintain a high level of safety.
Dr. Lee, do you want to speak about ultrasound guidance?
Yeah, I think the treatment effect and the recurrence rate is depend on complete ablation of a whole region. If we can make a complete ablation, the remain tissue easily regrowing and the symptom easily recurring. Symptom and recurrence. If we incomplete and sufficient treatment is caused, maybe many cases doctors immature treatment, and it create wrong perception of HIFU. Maybe it leads to misunderstanding about HIFU. I think the reintervention and recurrence is remained region after treatment. The remained region.
Can you tell us how thermometry links to recurrence?
Yeah, recurrence and the treatment effect.
Well, the question was related to thermometry and does knowing the temperature of the tissue that you're ablating, or the lack of knowing that.
Yeah. Usually, ultrasound-guided HIFU, we show the grayscale change in sonography, but type 1 fibroid is easily we can catch the grayscale change, but other type 2 or type 3 fibroid we can catch grayscale change is some difficult. So I have limited the shoot energy for 5-1, type 2, and type 3, and it's experience. I know that. Yeah.
So
it sounds like you're saying that it may impact the efficacy because you have to do different things, but can you go back to thermometry and safety? Do you see that being a problem? And then I'll let you take over, Susie.
Excuse me, my English.
So thermometry and measuring the temperature of the ablated tissue, is not having thermometry an issue for safety? Do you ever have the problem that the tissue is too hot and damages other tissue as a result?
Yeah. In case I treated the direct ablation is the focus inside of the uterus, and the near around the tissue will be diffuse heat energy. But this diffuse heat energy we call the cavitation effect. But it is the cavitation effect is not higher temperature, so it's a slowly increase the energy do not affect the near the intestine or near tissue. Okay. I'd like to show some case. Okay, this case is recurrent and insufficient treatment due to ablation, only direct focus ablation. HIFU have three types of effect. The first, direct ablation. The second is cavitation effect. It is increasing cytoplasm and looks like baking. And the third is damage of capillary necrosis, coagulation necrosis. She had one time of HIFU in previous another hospital. She received only direct thermal ablation in the center, but the margin region cannot be treated because it is near the vertebra and intestine. But we can use the cavitation effect, and the center is only direct thermal ablation, but we can get the cavitation effect near the margin of the lesion. We can totally ablate the whole lesion.
Dr. Lee, can you just clarify that when you're using, let's say, the higher energies or higher power for the more vascular fibroids, how do you monitor the treatment that you're actually getting these effects if you don't have the MR thermometry and the bubble cloud for the type 1 fibroids is not really appreciated on those other ones? So how do you safely monitor those treatments that you're getting the efficacy you want?
It is my experience. I do one type 1 fibroid, use 400 watt in ultrasound guided treatment, 400 watt, and use less than 24 seconds. And type 2 fibroid is less than 32 seconds. And if the type 3 is more than 45 seconds, I treat one focus, and the type 3 is not increased that we think.
Yep. Okay, thank you. And I'd also like to just add that Rosie from Chongqing HIFU has just added in the chat that there's this fusion technology with the MRI and the ultrasound. So you can see some, I guess, more subtle grayscale changes, and also with the 3D overlay that you can ensure precise location, but you are able to monitor the treatment. Is that correct? Yeah.
Yes.
Thank you, Dr. Lee. Dr. Stewart, I'm sorry, go ahead.
No, it looks like we're getting to the end of our session. Do we have time for another question, or do you want to?
Sure, one more question.
Okay, so the other question I had was to try to put fibroids in the context of other diseases that are treated with focused ultrasound. Again, in the early 2000s, the conversation was that in many ways, the blood supply of fibroids was an important asset because it kind of provided a heat sink. So you didn't get buildup of heat that caused, again, safety issues. And I think the primary contrast at that time was treating breast fibroadenomas, where you had fat insulating the tissue. So if the heat was too high, that you would get skin burns as a result. And has this dynamic of fibroids being very vascular tumors that's a problem for other kinds of treatment really been an advantage for focused ultrasound treatment. And I'll start with Dr. Hesley, since you were around for some of these initial conversations. What's your perspective of where we are?
Yeah, I definitely think with the ability to deliver more energy, deliver energy over longer and shorter times, that we can treat some of these fibroids that are more vascular. It's still most effective in the type 2 fibroids, but some of the fibroids that are quite vascular, you can choose to even use some of the MR angiographic techniques up front to screen and be able to target vessels. I think we'll see other individuals who are on the call who are also using some medical therapies to be able to augment treatment as well. So I think we've seen some significant improvements over time in both the technology of the device as well as innovation within the providers who are delivering the therapy to be able to target fibroids that are more vascular, or also adenomyosis as well.
Oh, and there's a comment in the chat that addressed the question to Dr. Lee with his large fibroids, but since you brought up the issue of targeting the vessels versus and potentially then getting the downstream effects of ischemic necrosis, such as pain and fever, versus doing the coagulative ablation of the fibroid. Do you think that that's a real dichotomy? Where is that played out? Because in the 2000s, the thought was that they were distinctly different kinds of treatment and would result in different post-operative profiles.
If I suspect type 3 fibroid, I use GnRH agonist pre-treatment 2 or 3 months. And then the huge type 3 fibroid vascular region is definitely reduced in size and more harder contact tissue. The type 3 fibroid can make maybe two type 2 fibroid, and then I treat one session of HIFU.
Can we ask you to address the issue of, do you get more pain and fever when you target the vessels like you would with uterine artery embolization versus when you target the fibroid aiming for coagulative necrosis? Taking medication off the table for right now, the two different approaches, do you get different patient outcomes in the short term?
Usually, I treated the pattern of a patient and amount of energy in type 1, type 2, and type 3. And if I prepare the real treatment image.
Yeah, no, if you can just answer the question about the patient in the week following treatment. If you target the vessels, do they have more pain and fever like they would after UAE?
Maybe uterine fibroid, I use the patient sedation and pain control. And I think we target the vessel is there is no effect of the focused ultrasound effect. We should focus the muscle layer, and we check the patient pain and the patient response.
Thank you.
So Dr. Hesley, do you want to address the question from your experience?
Sure. So I would say it's oftentimes difficult, as fibroids are often fed by more than one vessel, for us to achieve, complete ablation, or at least feel like we've achieved ablation. What I feel like I oftentimes do when I notice that I've tried to target an area where I suspect the vessel is, what I immediately notice when I'm treating within the fibroid is that all of a sudden I can use very low energies and achieve a larger ablated areas. And so at that point in time, we actually still continue around the fibroid and and try to achieve coagulant necrosis, because I worry maybe instead of truly occluding the vessel, that maybe we're just causing vascular spasm. And I really can't tell in the course of treatment which effect I've had. So thus, we've always tried, when we've seen this effect happen, is to go ahead and achieve more coagulant necrosis of the fibroid. With regards to your question regarding pain, we haven't had patients have significant, even when we've achieved treatment of many fibroids within a uterus, that their pain levels afterwards, they'll still have cramping, some discomfort, all just needing Tylenol. I haven't seen the uterine artery type effect of pain, and that's possibly because of the fact that the normal myometrium isn't being treated and being affected. It's the fibroid itself. So that's kind of been my hypothesis why we don't see more of the fever and the pain and the post-embolization type syndrome.
Well, thank you, Dr. Stewart, for posing that interesting question, and thank you to all the panelists. Dr. Stewart, if I had to put you on the spot, and we need to answer this burning question, right? What is the safety and efficacy of HIFU compared to the other standard of care procedures? Could you just sum up our conversation today? And
yeah, so I think that we unfortunately we've spent a lot more time discussing safety than efficacy, and I think that that's clearly where the technology excels. That to be able to have outpatient treatment, to be able to not have bleeding risk, not have bowel injury risk, and that the safety profile for focused ultrasound for fibroids is unparalleled. I think the challenge is communicating that, as Dr. Berman said, in the context of the general acceptance of complications of myomectomy as a given. There's been a lot of studies in the last couple of years that have really articulated how high the transfusion risk is for myomectomy, how high the issue is for surgical damage. And again, that's not even getting into second and third myomectomies where you have more adhesions and more problems. So I think the safety is very high. We haven't really addressed the efficacy in the short time we have today, but I think we have alluded to it. Dr. Lee has shown us how you can approach a large uterus in ways that were not even conceived of in the 2000s when we started the trials. But hopefully by the end of the day, we'll have a little bit more on efficacy. But let me stop there. I think that's a brief overview. What would you add, Susie?
Perfect. Thank you so much, Dr. Stewart, and thank you to all the panelists. Really appreciate it. I look forward to hearing your Q&A questions for the rest of the sessions as well. So if you could turn off your cameras, and people for the next session can start to turn on their cameras. And Joe has put up the next question. And I think, having discussed the safety and efficacy in the last session is a great segue into how we can optimize the machines to increase efficacy and improve safety and help clinicians perform this procedure better so that patients can benefit from it. So I welcome the moderators, Dr. Martin Boomsma and Dr. Loes Gnoren. Please introduce yourselves and you can take it from here.
All right. So thank you very much for the invitation. And as maybe some people here know, that we as a group have been treating uterine fibroids for a long time and doing research at several publications. It's mainly MR-HIFU. And we were very lucky, actually, that a lot of papers out there, we were able to review them because we were invited. And so it gave us an opportunity to take a closer look at the field of what's going on. I think the main reason that we are having this workshop is the fact that we need to manage the expectation management of both referring physicians as the patients, as the treatment team. Too often, we are being confronted with unexpected results, and for the better or for the worse. And I think it would be better if we could be able to increase the expectation management and to be able to say to a certain extent, we will be able to treat this patient with so much MPV, and it will reduce the complaints by so much %. And is that acceptable or not? So we have done our homework, but actually Loes has done her homework very well. And I'm very proud to introduce our PhD student, Loes Knorre. Loes, the floor is yours.
Thank you, Martijn. So we were asked to give a little bit of our view on this question. So I've talked with Martijn about this, of course, and we've prepared a few slides. And I'm very excited to discuss this question with our panelists as well. So can you please give me the next slide? So I always like to go back to the research, because to talk about a topic, you have to understand what is going on. So I just did a quick search on focused ultrasound for US, included original research articles from 2024, 2025, and we got 46 hits. And what was remarkable for me is that most of the hits are on ultrasound-guided, focused ultrasound, and much less on MR-guided. But that is something that we already know, because looking at the overall data, we see that on the US-guided FUS, there is more data present for more patients. However, very few comparative studies are present. Looking at the MR-guided side of the data present, we see that there is less data, but there are some high-quality RCTs also comparing HIFU to standard care. Next slide, please. And especially what we're a problem right now in the Netherlands is that it's still not reimbursed therapy for uterine fibroids, mostly because they say there's not enough high level of evidence present. And as is discussed in an accepted manuscript for The Lancet, they also say that the highest level of evidence is present on MR-guided FUS, but still not enough for total reimbursement. Next slide, please. But then again, what we do see in all the data that is present is that for both modalities, there is still a search going on for the highest effectivity of treatment and the lowest reintervention rates. So that's why we do want to take both modalities together. And I also would like to comment that there's almost no research comparing ultrasound-guided FUS with MR-guided FUS. And I do think that would be very interesting to find out, to also see if all the data present is translatable to each other. But that's another discussion as well. Please, the next slide. And then, of course, we're going to the question, why do we need to optimize our treatment? And in the end, of course, it's all about money. And with lower treatment times, you will increase cost effectiveness because you have more MRI time, for example, you can treat more patients. But also with the increasement of effectivity of the treatment, you can increase your non-perfused volume rate, which will lead to lower reintervention rates. And lower reintervention rates will again increase cost effectiveness and hopefully also increase the implementation. Next slide, please. So our view on this topic is two-sided. We believe that there is a big part about screening and also a part about optimizing the treatment itself. And I want to talk about the screening first. Next slide, please. And as we all know, as HIFU clinicians, that the eligibility for the treatment is multifactorial. You have your patient characteristics like the BMI, the thickness of the subcutaneous fat tissue, age of the patient, the presence of a scar, but also a lot of fibroid characteristics. And we have a lot of known fibroid characteristics like the size, the T2 signal intensity, the type of contrast enhancement on T1, vascularization. But I also think there might be more characteristics that we still do not even know. And next slide, please. And when looking at all the research that has been done in 2025 right now, we see that researchers are mostly focusing in trying to combine all these factors into one model to see what is the best screening possibility. So for example, machine learning models. Next, please. There has been research on a nomogram for predicting the efficacy on oxytocin experimentation and ultrasonographic features. Next, please. They've been combining MR-guided MRI characteristic with diffuse and weighted imaging. And next, please. And for example, they are trying to predict the outcomes based on uterine fibroids characteristics. Next, please. And lastly, also radiomics models, mostly on MRI sequence, has been used to create models. Next, please. But what is remarkable about all these studies, and we're really happy that these studies are done, but we mostly see that the models that are created in small groups and often single-centered and often not externally validated, meaning that all these models that are present are not directly applicable in clinical practice in other clinics. So we feel to make an optimal screening tool that we should collaborate with all the HIFU clinics, because we have a lot of data all together, but we need to get it together to make the optimal screening tool. And by collaborating, we will have the availability to combine our data and to externally validate the models that we created to hopefully create a perfect screening model that is applicable in every focused ultrasound center. Next, please. And we also feel that there is there is room for ultrasound in the screening process. And that's also that we see back in literature, we see there more studies are available on looking at vascularization of the fibroid based on ultrasound, for example, with contrast-enhanced ultrasound or using the Adler grade. And we believe this might be a good first screening tool to see whether a patient would be eligible and whether an MRI is needed. Because every gynecology has its ultrasound machine in the consultation room. It is cheaper, it is faster, but the question whether it is as effective as MRI screening is something that we should answer together. Next, please. And then we're going to optimizing treatments, because also one of the burning question is what is our dream machine? And of course, a dream machine has perfect sonications, a very short treatment time with good visualization, adequate thermometry on the MR-guided side, or maybe even a small or portable system to make it easier to treat patients. And that way, with the dream machine, we can hopefully achieve the highest possible non-perfused volumes in every treatment with low risks of complications. And next, please. But next to the dream machine, we also feel that there is place in researching the real-time non-perfused volume visualization. And Dr. Hesley, she told us a beautiful example for this, that when you have the feeling that you are done, but you don't know it yet, and you keep on treating the whole fibroid, maybe real-time MPVR visualization could help in this problem, because it would make sure that you can do targeted treatment, but also efficient treatment, knowing when to stop. And a few alternatives has been investigated nowadays, for example, diffusion-weighted imaging, susceptibility-weighted imaging, or IVIM or synthetic contrast-enhanced MRI scans. And we do believe that this might also very much help in the optimizing of HIFU treatment. Next, please. And then we circle back to our burning question, because how can we optimize the focused ultrasound treatment and what innovations are needed to enhance the adoption into clinical practice? And I've prepared a few statements, and then I would like to start the discussion. So next, please. So implementation will not work if effectiveness does not increase. And next, please. We need to create a research agenda based on the urgency. Next, please. And we need to collaborate with the HIFU centers. Next, please. So thank you very much. And I'm very excited to talk with our panel, and would like to ask our panel to introduce themselves and maybe already give a quick view on the subject. And can I start with Professor Hao Chen, please?
Hi, hello everyone. Thank you. Dr. Corinne for the introduction. So I'm Hao Chen. Actually, I'm from the Hong Kong University of Science and Technology. So I'm an assistant professor working on the AI, particularly AI and trustworthy AI for healthcare. So including actually HIFU. So I'm very happy to be here and also actually to discuss this actually important topics with the panelists here. Yeah, thank you.
And then Dr. Min Hei.
Okay, good morning, everyone. I'm so glad to join this part to talk about this topic. I am from Chongqing HIFU hospital, and you see, I'm now in charge of the HIFU doctors training. I'm doing ultrasound-guided HIFU for more than 15 years old, and I already treated over than 5,000 cases. And also, I work on this MRI-guided HIFU for several years. Since in my college study, I joined the MR-guided HIFU research group, and after that, I'm focused on this ultrasound-guided HIFU. So, going to join this topic. Thank you.
Thank you very much, James O'Reilly.
Hi, everybody. I'll start with, I feel like the junior on this panel. I've only been involved in HIFU for 13 years at this point. But I'll say I come at it from a slightly different perspective. I'm on the commercialization side and development of technology. And so I'll give you we'll call it less clinically weighted and more implementation details. But I'd like to come back just to something that Dr. Stewart said in her introduction. The benefits of the technology are not well understood by gynecologists, and I'll actually expand on that a little wider. I think part of our problem, as it relates to this particular burning question, is that our end user isn't a domain expert in ultrasound physics. We can't really expect mass market adoption with a knowledge gap there. And somehow we need to be able to close that gap, and maybe coming at it from the perspective of building an expert system that distills down Dr. Jae-Sung Lee's knowledge into something that someone who doesn't have that level of experience can actually pick up. I look forward to talking more.
Yeah, thank you for sharing that thought. I think it's really interesting, and I think we should circle back to it later. But first, I want to get the other panelists having time to introduce themselves. Jorik, can I give you the word for a short time?
Yes, thank you, Loes. Hello, everyone. My name is Jorik Slotman. I'm a technical physician at the Isla Hospital in the Netherlands, so a colleague of Loes and Martijn. And in previous years, I did my PhD research in the fields of MRI for treatments of uterine fibroids and bone metastasis palliation, and I was supervised by Dr. Boomsma. And in some of my previous research, Loes showed some images. I developed deep learning-based methods for volume measurement and contrast agent-free visualization of treatment effects during the MRI for treatments of uterine fibroids. And currently, I'm working as an AI data scientist in our hospital. And I want to thank the organizers for having me and also organizing this important workshop. And I'm looking forward to discussing the burning questions and also the comment by James O'Reilly.
Thank you, Jorik. And then, Sinyin, will you introduce yourself as well?
Sure. Thank you, Loes. My name is Sinyin Yo. I'm from Profound Medical. So my background is in biomedical engineering. I've been in the field for 15 years. And currently my focus is on different clinical applications using, different applications using MRI HIFU, and happy to be on the panel today to talk to all of you.
Okay, so thank you all for introducing yourself. And I actually would like to start with the first part of the question. How can we optimize focused ultrasound treatment? And I'm really curious about your idea. We have a lot of technicians and people working on making the treatment better, making the machines better. So I'm really interested in how you feel about the first part of the question. How can we optimize the treatment?
Yes, well, I think there are multiple factors that impede adoption. I think James O'Reilly mentioned one important one, and I want to add two other factors. I think the reintervention rate, that was also discussed in a previous session. I think that's maybe an issue that could be addressed by cervical technical innovations. And secondly, that hasn't been mentioned as far as I know, is the duration of the treatment. And I know more about the MRI for treatment, not so much about the ultrasound-guided treatment. But yeah, treatment of patients can take long, and that hinders the adoption because, the insurance is still a little bit hesitant in ensuring this treatment. And I think if we can speed up the process, and there are technical innovations to do that, then that might benefit the adoption from my point of view.
So if I'm going to chime in there, I agree with you in terms of speeding up the procedure. What we've found that's interesting from our perspective is that it's not actually the beam on time that's the issue in the treatment. It's actually, if we can improve the beam on fraction of time in the magnet, we can substantially improve our treatment times. And I think that probably, our colleague from Chongqing HIFU can probably speak better to the ultrasound-guided side of this. But if we can sit there and say, look, we can reduce the cognitive load on the treating physician to improve that treatment planning, and whether that's done ahead of time, and then you bring that treatment plan in via MR fusion, or whether in an ultrasound-guided setting, or also bringing that into an MR-guided session. Or you sit there and say, okay, we're going to develop an AI model that's going to have a better understanding of exactly what this, what the tissue absorption rate is and how we can suggest that planning. The other aspect of it is, and again, it was mentioned earlier this morning, is improving the mechanism of action. In some cases, it may not necessarily be required to ablate all of the blood vessels, or all of the fibroid. You can approach it from the vessel standpoint. You can enhance your ablation rate with microbubbles. You can do a multi-point rasterization. Which one of those techniques is going to be best suited for which fibroid? And I'm going to have to lean on the clinical side of this for that. I can tell you how to implement it, but I'm not the domain expert on what type is best for which type of fibroid.
Thank you, James. You've mentioned some really interesting points. You are from Arraeus, right? And it's fairly new. So I was wondering, could you maybe elaborate a little bit more about what's different from Arraeus than the machines that we already work with for a longer time?
And so that actually is an interesting question. Traditionally, this has been done with a geometrically focused transducer and a small number of elements, right? With a little bit of electronic steering, it's primarily mechanically steered. Arraeus has developed a dense phased array with full electronic steering. So the big difference here is we no longer talk about a single point of focus. We talk about a field, and we can change the size and shape of that energy deposition 250 times a second. It's fast enough to rasterize. It's fast enough to ablate. We have full power range across that entire field. We can do multifoci. What's interesting is one of the comments from earlier was concerns about critical structures in the beam path. One of the approaches that we're looking at right now is building out an AI model to actually allow us to null the field in areas, again, because we're now talking about a field, we can create areas of constructive interference and areas of destructive interference. So if we can actually null the field where you have those critical structures, all of a sudden they no longer become a problem.
Is there a size limit to this beam shaping, or?
Our array is about 15, 16 centimeters in diameter, and that volume extends about the same size into the body. So what that means is that patient positioning is much less of a problem for us.
That's very interesting. Thank you so much for the elaboration. Sinyin, would you like to comment on the proven side of the question?
Sure. I try to break it down from the whole workflow. So maybe in terms of treatment optimization, we should also think about who are we trying to optimize this machine for? Are we optimizing this for radiologists, or are we optimizing the machine usage for gynecologists? So I'm more experienced in the MRI-guided HIFU. So let's say our users, for example, lose yourself, and also from a time, you're radiologist by training background. So if you think about from the workflow perspective, if we can stop optimizing from patient screening, can we nowadays use AI to help us to screen the patient better for someone new who is going to start learning that? And then once you screen your patient, then you have a very good treatment planning tool that tells you already these are the parameters that you can use for your treatment. So before you put your patient on the table, you already know what kind of parameters you should start with to help you. And a lot of the, let's say, time spent in MR room is actually on manipulation of your uterus, of your fibroid, to actually create acoustic contact. Can we also find ways to improve the acoustic contact better so that we reduce the overall treatment time or MR time? And then when we finally start treating the patient, if we then also have, let's say, an AI-guided treatment planning tool that tells us already, in this position, you're able to treat 60 to 70%. But if you now manipulate it by this much, then you're able to treat 80%. Would that be sufficient? The clinician can now say that go start treating. And then once you do that, then you also have temperature mapping, thermometry to know what you're treating, and eventually you have your treatment outcome. So at least I would like to look at it as the overall workflow that we actually need to improve from patient screening all the way to treatment follow-up.
Yes, that's a very interesting view, and I totally agree with you. There are many points that we should optimize, and it's not just one place to focus. So thank you for that. From the ultrasound-guided side of you, can you comment on this, please?
Okay, thank you. As a gynecologist, I do a lot of uterine fibroid patients here. Yeah, this morning I just finished two very, very difficult cases. Why this case is very, very difficult because first we talk about the BMI. For my patient today, the BMI is over than 35. So the abdominal thickness is almost 6 centimeters, and also has a lot of myomas. The biggest one is over than 10 centimeters, and the other one is all around 5 to 8 centimeters, and 37 years old, and has fertility discernment. So what can we do for her? So this morning I spent 3 hours to finish all of the treatments. So why this is why ultrasound because in about 10 years ago I also do MRI-guided HIFU treatments. But for that time, yeah, MRI-guided HIFU system, that for me I think the most advantage is that the temperature we can use a T-map to know the temperature and the focus point, so we can know if the target if already necrosis. And but the disadvantage is that it takes a long time, and also there is limitation for the numbers, location, and the size of the treatment. So can I share some slides? Okay, so this is ultrasound-guided HIFU treatment. You can see we just monitoring by this real-time ultrasound. So we just evaluate the efficacy by the scan changes, just like this. This is a pancreatic cancer here, and this is what is happening after HIFU treatment. This is a multiple one, small one, and 4 months after.
Yeah, Dr. I don't think we see the slides.
Okay, thank you. Sorry. So yeah, this is what changed after HIFU treatment. So for ultrasound-guided HIFU system, now we can treat all of these indications. And also in some of our China hospitals, treated in advanced cervical cancer, recurrent ovary cancer too. So we have a lot of indications in gynecologists here. So changes just like this, yeah. But what I want to show you is that when I think for single myeloma here, I think both for myelomectomy or radio frequency ablation or anything we can do very well. But for multiple one, just like this with a lot of myeloma here, yeah, maybe traditional, the doctors just suggest to do hysterectomy here. But now patients just want to keep the uterus, so we just use MRI. We just use ultrasound-guided HIFU treatment. We can see even the very, very small one, smaller than 1 centimeter, we can get necrosis just one section treatment. So I think this is the advantage of the treatment. And today we are talking about how to optimize how to optimize these treatments, I think we need to consider about from two parts. One is for patients, how to choose the right patient, how to optimize the clinic protocol. This is also a very important one. And the other thing is for the system, for the machine. So for the clinic use, for the patient choose, for next section, we talk about the safety, and also we talk about the effects of the BMI, the type of the myeloma, and also the fertility of the treatment. The patients is very important. So now we optimize our clinic protocol. Now our treatment time, the average treatment room time is 1 hour to 2 hours. The shortest one for me is only 8 seconds here. And for the machine, we have to do something new. I think Dr. Cheng Hao, we are working together for that. Because for the AI, we just emerged the MRI with ultrasound imaging. That can we have the 3D, we have 3D guidance. So maybe I will share later my PPT. There is something wrong with my PPT. I just want to open it to show you our work. Yeah, I found it, sorry. Yeah, the advantage of this HIFU treatment is because it's totally non-invasive treatment here. So for keep the fertility ability is very important. I just want to show you one of my patients. This patient is 37 years old patient. You can see she had 2 surgery, and you can see there is no shape of this uterus, no cavity here. But after 3 times of HIFU, ultrasound-guided HIFU, we can see the cavity, and we can see here is the fundus of the body. And okay, after 3 times of the treatment, I just sent this patient to do IVF, and fortunately, she has a beautiful baby. And for this one, I think this one is also, we call it magic. This patient is also 32 years old patient. You can see how many myeloma here. We cannot see the safety, the cavity here. So as before the first HIFU, even the IVF doctor cannot take any aid. So she came to us. We do first HIFU for her, and then they took 5 eggs. And this one is after 5 times HIFU. We just repair the uterus. You can see the cavity occurred now. This patient is in the procedure of the IVF. You can see the cavity just occurred. Here is cavity. So I think this is the advantage of HIFU. But for these very difficult cases, once HIFU is not work. So we need to do combination treatment. This is the second thing we talk about, how to optimize this treatment. We do combination treatments for these patients. We just combine with HIFU and then GnRH, and 3 times we just combine the PEI with transverse vaginal to inject the ethanol.
Thank you very much, Dr. Min-Hei. I think we should, very impressive imaging, very impressive treatments. Also the baby, it's great to see that it has resulted such a in a live birth rate. But I think we should also give other panelists some time to reflect on the burning questions.
Okay.
No worries. So, Luz, can you offer the floor to someone else?
Yeah, sure. You quickly, the AI was mentioned a little bit, and I was really wondering how Professor Chen was thinking about this, as this is especially his kind of field. So please feel free.
Thank you, Lori. So so actually we are from UST. I lead actually a quite large AI team working on actually for the HIFU, especially actually the ultrasound-guided actually treatment. So I actually wanted to echo Xingyun actually, and also actually Dr. He about the how to actually optimize the treatment here. So my philosophy is like we wanted to promote the patient-centered care through the doctors here. So how to do that? My philosophy, since I'm from the engineering background, I wanted to see actually the AI is the future. So we wanted to optimize from the whole cycle. For example, actually, China, we have lots of populations, right? So from the pre-operative, we have the MR, and we do the diagnosis. We do the criteria screening for selecting actually the suitable patients, because there are many other treatment options there, right? So, but selecting the suitable patients with the most effective treatment outcomes while HIFU, with HIFU actually this is key. Once actually you during the pre-treatment, you also actually do the planning, right? For example, dose prediction, and also how to actually distribute actually these doses during the intraoperative. So this is important for the planning. So then the doctors actually can have a rough actual estimate, the treatment time, and also actually if there are any things they need to take care of, for example, the vessels and all these things. And second, actually, during the intraoperative, so we have the 3D, the modeling of in the pre-operative part, and then in the intraoperative part, you need to do the real-time navigation. So through the analysis, automatic analysis with the AI, we can actually do the real-time registration, navigation, where is the fibroids, and then what's actually the planning, the working. And in addition, actually, we're also working on the generative AI to improve the quality of the images, because we know ultrasound actually images, they don't touch the brain directly. There's water there, and then the quality may not be good as the regular actual ultrasound. So use the generative AI to denoise and also improve the quality. The third, actually, for the post-treatment, because we have actually many follow-up data. So how to actually monitor these patients actively, right? So we have the multimodal, the clinical records, the pre-operative MR, the intraoperative actually, all this, and also post actually, operative follow-up data. So we integrate this multimodal data to predict the recurrency, and also actually the in order to monitor them actually actively, and also actually do the quantitative evaluation, such as the NPVR, this kind of things, automatically. Then after treatment, so the doctors actually can immediately assess them based on this. All these actually are done based on the large scale data. So we collect actually large scale data. So actually hundreds or thousands of the patients' data. So build actually the vision foundation model. We call the large vision foundation models. That's like ChatGPT. ChatGPT is like the large language models, right? So we build them, but most here is the vision data, and also actually other non-vision data such as text and the clinical records and the follow-up data there. And then we unify them, integrate them together to do the regression, prediction, or segmentation, etc. And besides the advanced AI, we also integrate actually the extended reality or the augmented reality. So you can provide the real-time feedback during the intraoperative part. So in summary, I think my philosophy is that I wanted to bring in these actually advanced AI, extended reality, and the generative AI technologies into the HIFU actually scenario by leveraging large-scale data. And so we are working on it. So we are working with Dr. He and also other doctors in HIFU. So our AI team work with them. So yeah, that's actually, I think, by leveraging these technologies, we can maximize the patient's benefits.
May I comment on that? I
Sure.
really like that idea, and I think it's perfect. I think AI brings a lot of opportunities, and I also want to make use of this opportunity to advocate for collaboration, because
Yes.
you already mentioned that large data is needed for foundation models, etc. And we as a team developed a volume measurement deep learning based tool, and I also read the interesting article by Wen. They also developed a volume measurement segmentation model, and now other groups who also develop segmentation models. And I think we as a community could really benefit from a collaborative approach, that we bundle the data and create a very powerful segmentation tool, because I think it will accelerate future research, also radiomics, and you need the segmentation for a lot of purposes. And I think it will suit both worlds of the MR HIFU and also the ultrasound-based HIFU. So maybe just an idea, but as a community, we can try to come up with a collaborative segmentation tool and make it open source for the whole community to make use of it, because I think it will really accelerate future research in the fibroid HIFU business.
Definitely. I think actually we should really promote the institutional cross-niche collaboration on this, not beyond far beyond the segmentation. All these actually basically regression, post-operative, recurrent prediction, survival, all these things. I think we need to actually the larger data and to build more effective models.
I think we agree on that one.
Yeah,
sorry, James.
Yeah.
James first and Sinyan. Yeah.
Sorry, very quickly. What I'll say is not only just the models themselves, but actually the data. Mm-hmm. Because as we're going to sit there and build this out, one of the things that there's definitely a lack of is high quality available data to be able to properly train a model. And if the community were able to put that together, that would go a long way towards advancing the state of the field.
No, James, I totally concur here. Sinyan, you raised your hand. You dropped your hand. Is it by coincidence or?
No, I raised my hand. I'm going to speak next anyway. I can just drop my hand for the well-being. I just wanted to echo what James is saying. How do we streamline our data collection? That's one topic. And the next one is, once we actually have the model, how do we implement it across different hospitals? What will be the logistic of implementation? We always come up with the coolest technology for adoption, but what does it mean in terms of clinical practice and adopting that? Like, how much time are clinicians or technicians willing to invest their time in adopting the technology that we have created today? So maybe that's something we should also assess as well while we are improving our AI tool for them to use.
And the human factor, right?
Now, what I will say, just on the topic of AI, because one of the things I'm incredibly focused on is safety critical systems. And looking down the line as we build out AI tools to help with treatment planning and even closed loop feedback, there are going to be regulatory challenges. So if we can think about exactly how we're going to address those as we build the tool, we will be a lot closer to market by the time we have the tool.
Yeah.
Well, James, I think we have the knowledge here. Sorry, Jörg, you can.
No, go ahead.
So I think we have. I think on 2025, we have the knowledge how to build robust AI models, but it will take a big effort of the community. So I think I'm very happy to hear that AI is important. I think it's both important for ultrasound and for MR-guided HIFU. And I think this session does not give them enough time to actually brainstorm or determine the requisites for building a good AI infrastructure to meet the needs that we face. So I've heard something about selection of patients, AI models. I heard something about per-operative progression. And I think Loes herself can say something about how we are planning to actually monitor the treatment. Loes, can you say something about that?
Yeah, sure. I think you're talking about the IVM analysis, right? Yeah, so we are, as one of the things I mentioned that might be helpful in predicting real-time MPVR during treatment, we have just been prospectively collecting our data during treatment and making from diffusion-weighted imaging IVM analysis, and of course a lot with Jörg's help. But what we see right now is that it's very promising to actually give you real-time information, and we really hope to expand this one, and that's pretty. So it's like. and to expand it so we can actually use it to target our treatment, to actually see where you have MPV and also if you're already done. Because also something that has been talked about a lot is the treatment time. And we really hope that this is one of the tools that we can actually reduce treatment time. So we would also, of course, if we're talking about collaborating, maybe ask everyone, like, if you're doing MR-guided HIFU, make your diffusion-weighted imaging, because it can be really helpful in predicting your treatment and knowing when you're done, and also knowing when you're not done and when you need to continue treating. So I think.
Thank you, Luz. And something that strikes me is that everybody shows always their greatest pictures, right? And we see all these maximum MPVs. But as we all know, a lot of that is due to total vascular occlusion or compression or devascularization. And I think if we are more able to identify the feeding vessels and are more able to develop techniques to securely ablate them, we might be able to achieve total vascular occlusion for all the numerous fibroids out there. And although with ultrasound-guided HIFU, we've seen great results here. These are patients I would have never treated on the HIFU machine in Isala. So my compliments to China here. So I think that, and that's something, a lot of achievements are being made by combining techniques, combining AI, combining MR, combining clinical. So how could, for example, ultrasound, and you touched a little bit on that, Luz, how can ultrasound maybe help to identify patients that can be treated or cannot be treated, or can give information about how we set up the treatment plan? So there are some papers out there that say that the microvascularization assessed by ultrasound, and you mentioned in your introduction talk, could give information about the treatment, right? And I was also wondering, and that's a question maybe for Dr. Min, do you actually assess the vascularization during the treatment? So it's not only grayscale, but you also actually assess with power Doppler or with vascular imaging whether or not there's still vascularity.
Okay, during the treatment, the first thing we use to evaluate the efficacy is grid scan changes. And the second thing is we use color Doppler. And in China, now we combine with contrast ultrasound, we just use microbubble. Yeah, so this is three steps. First step, grid scan changes. Then color Doppler. If there is no blood supply inside, then we can use microbubble. And then if the treatment, if the MPV is enough, so we just terminated the treatment. If not enough, okay, we can give more supplementary treatment.
Excellent. And I would like to go to the hardware industrial partner here. James, you mentioned briefly we are treating large volumes. So how do you mitigate the potential side effects if you start ablating larger volumes at once?
So it's not so much that we're ablating larger volumes at once, but our field is very large. And so we have the ability to electronically steer within it. Our focus spot is still the same size, or can be as tight as all of the other systems. You can also make it more diffuse. So there's a difference between, I'll say, having a large field and being able to control that energy deposition. There is a question in the chat that I just wanted to address about dense arrays and aberration correction. The answer is yes. Dense arrays allow for aberration correction. One of the things that is required, though, actually is an accurate segmentation of the image. And I mean, that is something that we're working on. We have a little bit of aberration correction in our current system. However, with a larger data set and ideally an AI model, we can actually drive that back to get us a tighter focus and correct for, we'll call it inhomogeneous tissue.
Thank you very much, James. And then there one thing that Loes introduced is the very promising effect of ultrasound HIFU, but the lack of evidence and the lack of comparative trials. What does the panel feel about which clinical trials do we need? Are we ready for doing proper clinical trials in this field, or which trials should be done? Or please feel free to elaborate. Dr. Min, what is the reason that there is no comparative trials on ultrasound HIFU?
Yeah, this is a very good question. For ultrasound-guided HIFU, we already use more than 20 years in uterus. We do some of the RCT clinic trials, but yeah, then that's what we like. So this is our plan now. For me, because I'm in charge of the doctor training, so under my control, there are more than 20 centers, 20 hospitals here. Now we are working on this clinical, the multiple center treatments now. I think maybe, yeah, this is what we need to do. Yeah, especially now we are doing some comparable study for fertility protection, especially for small 5 myeloma here. Now we're working on this, and I think maybe this year we can publish this result. Yeah, we're working on this.
Okay, well, very exciting. We're looking forward to it. I think, Loes, we need to wrap up at 4, right? Or at the Dutch time?
Yeah, that's true. So we'll have 5 minutes more. Let me see. There is one more question from the chat asking, how long does it take to ablate 2 separate fibroids, such as a 5 centimeter fibroid and an 8 centimeter fibroid? Wait.
Maybe I could do some sort of summary and see if this resonates with the panel. Is that okay?
Yeah.
So I think we all agree that collaboration in this field is mandatory, right? Everybody say yes.
I think if we're not collaborating, then we're all just duplicating the same effort in a whole bunch of different silos.
I always say we're doing a lot of things, but we're not doing the right things, right? So I think to collaborate, we need some sort of infrastructure. Am I correct?
Yes.
Okay, so we agree on. So we can. So then these are prerequisites to work on good AI models, right? On the hardware, we know that there can be some improvements, and for me, I think the collaboration between the industry and the clinicians is not optimal. And I think that could be improved, and it should be on the agenda. Do people concur? Or people disagree?
I think that we've made some pretty good strides, at least from our perspective, on the hardware side. I mean, that's kind of where we've been focused, and there's a number of problems that have been brought up that we don't see anymore. We don't have any near field heating. We can, scars are not a problem. We can delineate those, and our current tooling allows us to actually mitigate any sort of cesarean scar problem. The issue that we've got, and this is where the collaboration helps, is getting more domain knowledge to try and understand exactly what that end user needs. At this point, I think it's actually a software problem, not a hardware problem.
Okay, that's good to hear. So software is also per-operative monitoring. Huh? So what's going on actually? What are we doing? And one topic I did not hear is the temperature mapping. We sometimes get temperature disturbances, or the spatial resolution of the temperature mapping is not optimal. So I think I think this addresses more like, and as you were saying, James, that we should draw a research agenda. So in community. So is that something that people feel that is necessary or could be of benefit if we all together draw a research agenda of the burning topics in the different?
Yes, I think that would help. And maybe there are some lead institutes that can take a lead in some of the agenda items. And regarding thermometry, I think one of the issues is a discrepancy between the necrotic volume based on a thermometry, right? That's based on the biological model with the thermal dose, and that may not actually match the contrast-enhanced based non-perfused volume that we're seeing. So there, I think, is one issue, is like, how can we synchronize or better synchronize the thermometry-based non-perfused volume representation together with the non-perfused volume as visible on the contrast-enhanced scan, because that would also be able to solve a lot of problems.
Absolutely, because you can't, without actually being able to accurately predict that, you have very high degree of difficulty suggesting a treatment plan.
Yes.
And I also would like to shine a light on what Dr. Chen said about generative models, not only imaging, but also clinical, but also using AI to improve the image quality. And we also know, we don't know what the effects will be on screening, right? So if you change your acquisition, or not acquisition, if you change in the image domain, you make changes in how you get the final imaging. And this is the domain where you actually are going to apply your AI on. And so this is a very dynamic field, and it requires a lot of agility. And so this is also a problem. If the imaging field changes all the time, we get into trouble with our prediction model if MRI parameters are helping us in the prediction. So this also highlights the necessity of uniformity a little bit on the least. That's why we say the basic uniformity of imaging, or the basic uniformity in clinical data parameters should be available across all sites. Is there something I have forgotten, my dear panelists, that should be highlighted? Is there something not said that should have been said?
The only other thing I think that we did touch on was looking at the various mechanisms of action and trying to understand which one of those are most appropriate for which type of fibroid, and possibly leaning into multiple mechanisms of action across the course of a treatment. So
do you really mean direct ablation, total vascular occlusion, histotripsy? Do you mean?
I mean whether you're talking about Dr. Jason was talking about leaning into the cavitation model, whether you're talking about enhancing with microbubbles or oxytocin, whether you're doing multi-point rasterization. These are all different tools. And given what we know about fibroids and the way that they absorb the ultrasound energy, I think different fibroids may require one or more of those tools in order to actually have a successful treatment.
Yeah. And one more thing to that also regarding the outcome prediction. Like right now, we are mostly focused on the non-perfused volume ratio, but there is also the proposal of the non-perfused or the total fibroid load versus. So there are multiple outcome parameters, and I think they also can depend on fibroid type regarding long-term outcomes, so symptom reduction. So also regarding outcome parameters, we should look into the different types of fibroids.
Thanks a lot for all these extra comments, James. George, you're totally right. But the more parameters there are, the more patients we need, the larger the data sets need to be, and the more intense our collaboration needs to be. So I would like to express my special thanks to Luz. Again, great achievement, great work. I think we have collected a lot of information that we can use for the white papers we will try to produce after these meetings. And for now, I would like to close this panel meeting. And I would like to thank again all panelists. I know you're all very busy professionals, and I really appreciate the time and your intellect in making this webinar so fruitful as it has been. Thank you very much.
Well, thank you to the panelists for that most interesting discussion, and thank you to the moderators for doing such a great job in preparing us for that session. So let's start again with session 3. Session 2 was resounding success. I think we've heard agreement that we need a working group at minimum to explore what research in AI needs to be done to improve treatments, and innovations in software and hardware are imminent. So thank you all for that. And we're going to move on to session 3. Our moderators are Dr. Selva Subramanian and Dr. Peggy Ganuni. I'll let you guys introduce yourselves, and thank you so much.
Thanks very much, Susie. My name is Peggy Ganuni. I'm a radiologist here at Stanford. I've been involved in focused ultrasound procedures for about 15 years now, a variety of them. It's my privilege to serve on this panel as a moderator with Dr. Selva Subramanian, who's a consultant OB-GYN and a subspecialist in reproductive medicine at the Makota Medical Center in Malaysia. He's also the vice president for HIFU for the International Society of Minimally Invasive and Virtual Surgery, and he runs Malaysia's first ultrasound-based HIFU center at Makota Medical Center. Our burning question for this session is, in what patient population would HIFU for fibroids be most beneficial, especially as it relates to preserving fertility? Our panelists include Dr. Kirsi Jornan, who's a consultant in obstetrics and gynecology and minimally invasive surgery. She's a leading gynecologist in Turku University HIFU Center, Finland. Dr. Jordi Rodriguez is a specialist in obstetrics and gynecology as well. Since 2016, he has been the head of the HIFU unit at Mucha Terrassa University Hospital. He has over 17 years of experience in the treatment of uterine fibroids and other pathologies with ultrasound-guided HIFU, including treatment of adenomyosis, and he's completed more than 1,000 HIFU procedures. Dr. Ertan Sardogan is a professor of gynecologic surgery at University College London Hospital, also a consultant in reproductive medicine. He's a former president of the British Society for Gynecologic Endoscopy and is the current president of the European Society for Gynecologic Endoscopy. And Dr. John Petrosa is the former division chief for the Division of Reproductive Medicine, IVF, at Massachusetts General Hospital, the current director of OB-GYN Business Development and Network Collaboration, the director for the MGH Integrated Fibroid Clinic, and a past chair of the Society of Reproductive Surgeons. It's a great privilege to work with you guys on this panel, and I look forward to hearing your comments. As a brief introduction here, I thought we could start with some data that has been accumulated for us. Lou's kindly gathered some of this together for us. The references are there at the bottom of the slide. This represents an analysis of 25 articles looking at live birth rates for UAE, ultrasound-guided HIFU, MR-guided HIFU, and as well as radiofrequency ablation. And one can see the live birth rates are in the range of 70% or so, 74% around for ultrasound-guided HIFU, 70 for MR, UAE 70 as well, RFA 60, and microwave lower with smaller numbers there. And you can see the miscarriage rates as well. The number of pregnancies obviously varies considerably among these studies, as well as the mean age of the pregnant women. And the miscarriage rate was highest in the UAE group there at 19.2%. Ultrasound-guided HIFU and UAE both had low rates of placental abnormalities that were presented, between 2 to 3%. And you have to really look at, because of the small numbers in the various studies, you have to look at the pooled estimates of pregnancy ranging from around 18 to nearly 80%. For the ultrasound-guided and MR-guided focused ultrasound approaches, around 17 to 45% for UAE, and again, small studies so far with RFA, 2 to 8% there. Basically, these minimally invasive treatment options, uterine-sparing treatment options for uterine fibroids, are all potential approaches for patients wishing to preserve fertility. And at least the first 3 have comparable reproductive and obstetric outcomes among the different techniques. So hopefully this will start us off, the conversation off. I did want to point out there's no randomized control trials assessing fertility for MR-FUS, at least. The best evidence for MR-FUS comes from a prospective cohort of 51 women who underwent MR-guided focused ultrasound. Among these women, 54 pregnancies occurred. Mean time of conception was 8 months after treatment. Live births in 41%, and a 28% spontaneous abortion rate. As far as things like ovarian reserve function, there have been several studies that have looked at that after HIFU treatment and have pointed out that HIFU has no significant effect on ovarian reserve. 74 fibroid patients who underwent FUS, they looked at median anti-Müllerian hormone levels before and after treatment, essentially no change before and after. And another prospective study that enrolled 79 patients with fibroids or adenomyosis, again, showed no change in AMH levels 6 months after ablation. Same thing has been shown, I believe, in the first study where they compared UAE and FUS and found that UAE decreased AMH more at 1 year than FUS did and had a significant impact there. So there's that data. And then from there, I'd like to hand this off to Dr. Selva, who has a case study that he wanted to use to help us start off the conversation. So Dr. Selva, just let me know and I will start switching slides for you whenever you're ready.
I thought this will come a bit later. Maybe we can ask the panelists on what their views are on this ablative therapy for patients who want to get pregnant. And maybe we bring the slides later. Is that okay, Pedji?
Absolutely. Yeah, whenever you'd like. So, yeah. So if we can go back to our panelists, then really the question has to do with the best patient population and specifically what they think of the use of focused ultrasound in terms of fertility. Dr. Rodriguez, would you like to start off perhaps addressing this question? How are you selecting patients? What are you telling them about the use of focused ultrasound if fertility is their main goal?
Yeah. Okay. Okay. So nowadays the evidence is although limited, suggests that HIFU doesn't damage surrounding myometrium. You have told us. And doesn't damage endometrium and ovarian function, okay? If we also take into account the morbidity of surgery, I have it clear. For me, I propose HIFU in every patient. Okay, that's the first comment. I propose HIFU in every patient because the non-invasive technique, okay? Okay, in every patient with symptomatic uterine fibroids with present or future desire for fertility. Of course, in patients who are candidates for this treatment, of course, Funaki type 1 or 2 fibroids with medium or low vascularization fibroids, of course. But okay, if we concrete in some patients, for example, in patients with FIGO type 0, type 1, or type 2, of course, the standard treatment is hysteroscopic myomectomy. I know, especially in fibroids of 1 to 3 centimeters, of course. But for example, in patients with fibroids larger than 3 centimeters, FIGO 0, 1, or 2, it's very difficult to remove completely with hysteroscopic resection. For example, 4 centimeters, 5 centimeters. For me, these patients are very good candidates for HIFU, okay? This is the first group of patients, okay? Another very interesting group of patients is for example, patients with fibroid type 3 or 4, totally intramural fibroids, small fibroids, not distorting uterine cavity, okay, with fertility problems. Okay, the evidence is clear. This group of patients have a low likelihood of, success in the in vitro fertilization. You know what I mean? And for me, this group of patients is very, very interesting to treat with HIFU therapy. Okay, 1 centimeter, 2 centimeters, 6 centimeters of intramural fibroid, not distorting uterine cavity. These women have lower likelihood of success in vitro fertilization. Perfect candidates for HIFU because surgery is, for me, totally contraindicated. I think all the gynecologists are agreeing with me because it's not possible to treat because it's very aggressive to do myomectomy. Therefore, for me, it's very good in all patients because finally, it's a non-invasive treatment. In my experience, I'm very confident because HIFU is the safety of this treatment is very high. It's a safe treatment. We don't have any complications in the last 5 years. We began to treat HIFU in 2008. Okay, at the beginning, in the learning curve, we have some complications, first and secondary risk in burns, but in the 5 years, no complications, only mild pain after procedure. All the procedures are outpatient procedure. Okay, the evidence, nowadays the evidence is clear. HIFU is a safe treatment, okay? Another thing is the efficacy and the efficiency. Okay, but the safety is clear. And in this group of patients, it's perfect, okay? Sorry, I'm speaking a lot of, but if you have some questions or you know,
Dr.
Okay.
Have you been tracking pregnancy outcomes in your patients?
Sorry?
Have you been tracking pregnancy outcomes in your patients?
Yeah, we have published 3 years ago our series of 71 pregnancies, but okay, it's only a observational study, okay? But the patients who achieve a pregnancy, they don't have any problem with the pregnancy. Okay, we achieve a full-term pregnancies with few complications, with few perinatal pregnancy complications. And okay, with our limited experience in pregnancies, of course. Okay, in this area, in this issue, we need more evidence, of course, comparative studies, more cases, but the clinical experience is very, 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 very important and encourage us to continue to treat these patients, okay? Okay, and our series of pregnancies has a very high, the mean age of our patients was 41 years old, okay, in our series, 41 years old. It's normal to have a miscarriage rate of 30%, for example, in our series, because of these 560 patients of our study, only 160 have a desire for fertility. And in this group, the mean age was 57 years, sorry. And of course, that's because probably we have a high miscarriage rate, for example. But okay, this is our limited experience. And we have 43 babies in this series because now we have, nowadays we have 100 pregnancies, okay? And with 61 successful deliveries. And okay, and the rate of, for example, the cesarean section rate is low, 40%, okay? And of course, we have experience in vaginal deliveries in these patients with no problem. Finally, our conclusions is these patients can, treated with HIFU, can achieve full-term pregnancies with few complications and with vaginal delivery without any problem, okay? With a few problems.
Do you give them specific advice about how long they should wait after the treatment before attempting to become pregnant?
Yeah. Okay. You know, all of you know that the uterine fibroids are heterogeneous pathology, okay? Different number, different location. And when we treat with HIFU, it depends on the location of the fibroid principally. For example, if we treat a FIGO 0, 1, or 2 uterine fibroid, and we had success with a very large non-perfused volume, okay, we have to wait enough time to achieve a complete restoration of the uterine cavity, okay? Because as you know, after HIFU treatment, the fibroid will shrink, okay? And finally, to normalize the uterine cavity. Sometimes it occurs in 3 months, minimum of 3 months in FIGO type 0, 1, or 2, okay? But it depends on the size, okay? If the fibroid is 3 centimeters, probably in type 1 or type 2, in 3 months is enough to go to get pregnant. But if the fibroid is 4 or 5 centimeters, probably you have to wait more time. It depends from the case, sometimes between the 3 and 6 months.
That's very helpful.
Yeah.
That's very helpful.
Yeah.
Experience.
But in fibroids with no uterine, with no cavity distortion, my advice is, you can go to get pregnant immediately, especially in patients who have 34, 55, 40 years, okay? It's not necessary to wait because it's very important, fast.
Sure. That's great, yeah. Dr. Thank you. Dr. Jordan, what's your experience? How do you decide who you select for this treatment? And also how you counsel patients about fertility?
Yes. So good morning or afternoon from Turku, Finland. So this is, I think, it's a huge question, the fertility and HIFU, and for sure, for the question that is HIFU safe for those women wishing to preserve the fertility for future, and I think we've established that it's quite safe, and I re-advise here that it's safe to get pregnant afterwards. But I think it's a much more trickier or more difficult to question whether this is the preferred treatment modality for infertility patients. I think these are two totally different patient groups. And for infertility patients, we seem to be a bit more conservative than the previous speaker. I think that first of all, if we think about fibroids and infertility, we refer the patients to the fertility unit because I think that the infertility is a multifactorial thing or situation. So it's very important to establish that the fibroids are, in fact, the cause of infertility. And in most cases here in Finland, we advise for if we think that the fibroid is the cause of infertility, we advise for surgery. So in very limited cases, we've gone for HIFU.
Thank you. Thank you. Dr. Petrosa, as a doctor specializing in this area of assisting women with fertility, what's your perspective on the use of HIFU versus myomectomy, for example, in addressing fertility concerns in women? Do you recommend one versus the other? Have you recommended one versus the other? What's your perspectives on this?
It's a very, very difficult question, right? And there's a lot of complexities to this. As a reproductive surgeon, I tend to sort of favor surgery over alternative modalities just because of the limited data that we have. And let me be clear, the data that we have on surgery, myomectomies, isn't great, right? We don't have a lot of good data saying doing a myomectomy improves outcomes dramatically. We have a few studies that are developing, but what we do have is we do have a few studies that are showing a benefit of doing myomectomies in certain types of fibroids like the FIGO 0, 1s, 2s, and 3s. We do have some basic science studies looking at implantation factors that we know are clear that they are involved with implantation. And when you do a myomectomy, you see an improvement in those implantation factors. So those are very, very promising, encouraging data for doing a myomectomy. But for alternatives, including the HIFU, we have very, very limited data. And it gets difficult because it's encouraging to see the pregnancy data. It's encouraging to know that a patient can get pregnant and have a safe outcome. But we don't know the denominator when it comes to fertility, right? There's been no study that I'm aware of that says, okay, these are patients with infertility. We're going to follow these patients. We've made sure that the only reason for their infertility seems to be fibroids, and therefore we are seeing no detriment to their implantation or their ability to conceive. That denominator is not known, or if it's known, it's very, very small numbers. And because of that, it's hard for me to tell my patients, I'm seeing infertile patients in my infertility clinic, to say, I have enough data to say that this is going to be safe for you, that you're going to have the same ability to conceive. And therein lies the problem. So I have a little bit of data supporting myomectomy. I have very limited to no data saying that HIFU is going to not hurt their ability for implantation.
Does the AMH data impact your decision-making at all?
I think the AMH data is great, right? And I think, compared to, I was on a panel about a year ago for the interventional radiologist looking at uterine artery embolization. A big concern, right? Who wants to recommend uterine artery embolization, knowing that it can impact ovarian function? And even though there's modalities to try to limit that, that's a big concern for patients. The higher miscarriage rate that we see with uterine artery embolization, a big concern. And the lack of data, just like HIFU, looking at those patients with infertility and their impact on implantation. So, it's very, very difficult. So I think for now, I tend to take the conservative approach, just like Dr. Jordan. I tend to go toward the established practice that we have to do the myomectomy. But as a reproductive surgeon, someone who's been doing this for 30 years, my big concern is not a lot of people do good laparoscopic myomectomies or myomectomies in general. It's a very tough procedure to learn. The skill set is very, very difficult. And I think a lot of people don't do myomectomies well, right? So if you can go to a skilled surgeon, it's great. A lot of people don't go to a skilled surgeon. I've seen some bad hysteroscopic myomectomies for type 2 fibroids. And I go, oh my gosh, this patient just had her entire posterior wall endometrium removed. I think these alternative approaches are the key. And I think the data hopefully will be encouraging. And I think once we get data on implantation and reproduction, I think it will be the gold standard, but we just need to have that data.
I presume women after these myomectomies at your institution as well are recommended to deliver via C-section. Is that correct?
Not always, right? And that's a very, very good question. And we actually have put together a review that hopefully will get published. We're submitting it to one of our journals, looking at the data. The data on when to do a myomectomy or when to do a C-section after a myomectomy is not very clear, right? There's no guidelines that we have. Clearly, if you have a FIGO 4 fibroid and there's very little overlying myometrium, and you see when you do the myometrium sort of decompress and fill that space, that patient probably doesn't need to have a C-section. So it's a little bit complicated, but it's not clear. And I think one of the benefits of HIFU is that, yeah, if you don't have to make a big incision in the myometrium and you have very little damage, what a wonderful thing to say you don't need to do a C-section, especially in the United States where our primary C-section rate is 36%, right? 36%. If we can eliminate even 10% of that, that's going to be a dramatic improvement.
Do you think that would be an important factor for women choosing between these options? Have you found that that's an important issue for women?
Oh, yeah. It's a very common question. Am I going to need a C-section? I often say I don't know until I do the surgery, right? And so to be able to do a HIFU and say, you know what? You're not going to need a C-section because we haven't created harm to the myometrium will be fabulous.
Are you suggesting that a randomized trial is necessary, or do you feel that it's something where you can follow a cohort of patients looking at some of these implantation issues that you were talking about after myomectomy?
I think the easy approach in my mind, because it's very difficult to do these patient studies, right? Otherwise, we would have had much more data on myomectomies years ago. But it's very difficult to recruit patients. So I think the easiest thing to do is to look at these implantation markers in patients who, in general, but in patients who are trying to conceive, but in any patient, to be honest with you, and look to see if there's any detriment or improvement with these implantation markers. If you see an improvement, that is your first early sign that there doesn't seem to be a negative impact. And then you can go into these patient studies saying, okay, let's look at patients with infertility. And this is where working and collaborating with an infertility clinic is paramount, because you have patients with infertility, you can control for age, BMI, diagnosis of the infertility, number of embryos you put back. We can screen the embryos to make sure there's no aneuploidy to reduce miscarriage rates. So we can control a lot of facets. And now you can control things. You can look at patients where you don't do a procedure to remove the fibroid and do a HIFU. And you can get some very meaningful data in a much quicker time period than following a cohort out for many, many years.
Very helpful. Yeah.
Dr. Perhaps I can give my view on this topic. Okay. Now, I am actually a laparoscopic surgeon and a fertility specialist, and I got into HIFU in 2021. And I do ultrasound-based HIFU. And I've found the benefits as described by Dr. Jordi of HIFU for patients with fibroids. So my approach actually is to tell the patients that we have two modalities of treatment. We have HIFU and we have surgery, laparoscopic surgery, and we let the patient make the decision. So I tell the benefits of HIFU, I'll tell the benefits of myomectomy. Each has got its good point, as what John mentioned, Dr. Petrozo mentioned. HIFU has got these big benefits of no incision on the uterus, whereas myomectomy has the benefit of removing the fibroids completely from the uterus, as opposed to HIFU, which the fibroids are still lurking behind. An ablated fibroid is still something there lurking behind. And if they don't get pregnant, they will blame me for leaving the fibroid behind. So I'll let them make the decision. But as usual, patient will ask me, what do you think, doctor? And my policy is that for younger patients, for those who are less than, say, 35, I would err to do HIFU because they have got a longer time for pregnancy. And if suppose they don't get pregnancy, we have an option to actually go back and do the surgery. So I'll choose HIFU for them. But for the older patients, for 36, 37, 38, I am always worried that time is a problem. So I will say probably surgery may be a better choice because you remove the fibroids, you have a clear mind, you can probably go and get pregnant. So that is the policy that I'm having, because I have had experience of patients in the later age group whom I promoted to do HIFU, and they don't get pregnant, and then they come back to me and say, maybe I should have chosen surgery. So giving them this option, I have kind of avoided the problem of them blaming me for not choosing them. It's always a problem when you've done HIFU and they don't get pregnant and you want to do IVF and there's some fibroids left behind and they say, no, maybe I should have done the surgery, and that will be a waste of time. So this is the policy that I've been following.
That's very helpful. Dr. Petrozo, a question from the chat that came up. What is the time you recommend, similar to the question I asked Dr. Rodriguez, what is the time you recommend patients wait after myomectomy before attempting pregnancy?
Yeah, most of the data on healing of the myometrium is based on some C-section data and a little bit of fibroid myomectomy data. In general, for my patients who are going through fertility treatments, I give them at least 3 months, but it also depends on the extent of the dissection I did during the myomectomy. If I take out 35 fibroids, that's someone who's probably going to wait at least 6 months before they start any fertility treatments. If I take out a large FIGO 2.5 fibroid, they can probably get by with waiting 3 months. And by the time I get them into their cycle, and by the time they have an embryo transfer, another 2 months has already gone by. So in essence, it's really 5 or 6 months by the time they're actually with the pregnancy.
Very helpful. Dr. Jordan, is your experience similar?
Yes, our policy is the same as something between 3 to 6 months, depending on the extent of the surgery.
And for you as well, Dr. Jordan, there was a question asking about different country-by-country differences. So in Germany, they exclude patients with FIGO 0 or 1 fibroids that are interested in future fertility from HIFU treatment. Do you have a similar restriction on FIGO subtypes?
No. Actually, the majority of patients, a large proportion of patients that in our patient that we followed have FIGO 2 fibroids, because I think this is a quite challenging patient group. If the fibroids are really big, of course, if they're less than 3 centimeters, quite easy to remove hysteroscopically. But if they're like 4 to 5 centimeters, it's quite tricky surgery. And I think that we've even done this two-step procedure. That first we've done HIFU for this kind of fibroids and allow like 3 months for the fibroid to shrink, and then it's been quite easy to remove the rest of it hysteroscopically. And this is something we also offer to our infertility patients, because this way I think that we get the benefit of removing the fibroid altogether and avoiding repeated hysteroscopies, for example, which present also like risk for uterine scarring and so on.
How about you, Dr. Rodriguez? Are you limiting the FIGO subtypes for future fertility, or it sounds like you were offering this very broadly, independent of FIGO subtype to patients? You're on mute, Dr. Rodriguez.
Okay, with HIFU technology, it's possible to treat fibroids of all locations, including FIGO 7, but of course, FIGO 7 fibroids is more difficult, and we have to be careful, because when we are treating this type of fibroid, FIGO 7, it's probably during treatment, this fibroid is moving, it's more difficult, but we have some cases of very good results. And but probably FIGO 7 is more difficult. In some centers is contraindicated for HIFU, yes. But all the locations, the rest of locations is possible to treat with this technology.
And what about the vascularity of the fibroid? Does that impact your recommendations in terms of patients who desire future fertility? Do you exclude the hypervascular fibroids, knowing they're going to be more difficult?
Yeah, this is a very important problem, because, as you know, very high vascularization fibroids, the response is not the same, of course. And sometimes for example, in patients with the big fibroids is 7, 8, and 9 centimeters, and is very high vascularized fibroid, probably I don't recommend this treatment. In patients with fertility desire, or if is waiting to in vitro fertilization. No. Finally, the patient decide this treatment, of course. But at the beginning, we have to inform that the probability of success is lower than in the other types of fibroid. And this patient wants to get pregnant in a short place of time, of course. And the problem is when you treat difficult cases, big fibroids with high vascularization degree, if finally the treatment doesn't work, the patient, 3 months, 6 months of follow-up, and finally undergo a surgery, the time is more large and is not positive for patients with a desire for fertility. And of course, if the pre-study is not a very good candidate, probably I don't recommend this treatment. 8 centimeters with high degree of vascularization, finally patient decide to try it, okay, you have a 20% of probability of success is very low. Okay, you decide. In my experience, probably because the Europe experience is different than in the Asiatic countries. In Korea, they are treating very huge fibroids. Dr. Selva has experience in this type of fibroids, but I don't know what is the secret in, because they treat huge fibroids with high degree of vascularization. I know in Korea they used microbubbles. I used also microbubbles to improve the results of HIFU, but in Korea they have a Zonazoi. I think it's called Zonazoi. Is a very powerful contrast enhance, and I don't know if this is this for this thing, but they have a very good results, including this type of patients. Huge fibroids, high vascularization, Zonazoi, bam, very good results. Okay, in Spain we don't have this treatment. It's not approved in our country, and I cannot use it. But in my experience, I recommend hyper-intense fibroids, of course, Funaki type 3, okay, and high vascularization, 8 centimeters. No.
You just don't select them. How about you, Dr. Jordan? Do you also select against those fibroids specifically for women who are interested in future fertility? Maybe don't have
we're restrictive in selecting patients altogether. So it's a really medical sort of search for right patients, and I think that actually like 50 to 60% of women who are referred to us, because here in Finland the HIFU is reimbursed. So I think it's quite a different setup than in many other countries. So we think that they are not suitable, and it's not just the vascularity, because we use, for example, oxytocin, which reduces the the perfusion of the fibroids dramatically. But I really think that, of course, the vascularity of the fibroids go really often together with the cellular structure of the fibroids. And for example, for this vascular Funaki 3 fibroids, we exclude them from HIFU, whether they have a wish for future fertility or just seek for symptom relief.
You make a very important point, which you said in Finland, this procedure is reimbursed. So that wild card is removed from your thought process. What do you think about the idea of treating women with fibroids before they become symptomatic? Given that you have an essentially non-invasive approach, they don't have to pay out of pocket for it. Why wait for the fibroid to become a problem? What do you think about that?
Yes, would you start a medication, for example, that would restrict the future growth of the fibroid just to sort of prevent future problems? I think that majority of the fibroid patients are asymptomatic. Over 60% present no symptoms by the age of 50. So it's really difficult, I think, to select those patients that would benefit from a long-term medical use, or for even though this is a really safe procedure, we all know that there is no procedure with no complications. So always something happens. So I think this is a tricky question, and I think that the preventive and I think that we even do not have proper knowledge of the behavior. We cannot predict the behavior of fibroids well enough to pick those women or those patients that would benefit from these sort of really early on treatments, either medical or radiological.
My opinion in this topic is, of course, we don't know, we cannot predict the behavior of the fibroid. Of course, I agree. But of course, all we know the natural history of the fibroids in young patients. In young patients, the small fibroids, the natural history is to increase volume. We don't know in what rhythm. Okay, 1 centimeter per year, we don't know. 2 centimeters, 5 centimeters, but in 20, 25 years old women, the natural history of fibroid is to increase. We have few patients who come to our HIFU unit with concerns about his fibroid, his small fibroid, asymptomatic small fibroid. I'm a young patient. I'm concerned about the future because I'm going in the future. I will be want to be pregnant, of course. And I propose HIFU as a preventive treatment. Okay, okay. I know this is a very I cannot support with evidence, but of course, and these few cases is perfect. Of course, with inside the protocol, hypointense fibroids, Ponaki type 1 or type 2 with low or medium vascularization. Okay, we can treat with a very good response, and 1 year, 2 years, 3 years of follow-up, the fibroid is small fibroid and no problem. Okay, probably we have avoided a future surgery in these patients. I don't know. I know is a conflictive decision. Okay, in a group of professors, and okay, because I cannot support this idea with any evidence. But in the practice clinic, we have few cases, and probably we have avoided surgery, of course. But
this
okay,
was meant to be,
it's only my opinion.
Yeah, this was meant to be controversial. John, Dr. Petrosa,
controversial, yeah.
This as well. What are your thoughts, please?
Yeah, thank you. I mean, you've touched a little bit on the holy grail of fibroid treatment, right? To be able to sort of diagnose this early on in high-risk patients and to be able to treat them early. And I think that should always be our goal. I think here in the United States, where we have a large Black population and fibroids tend to be quite aggressive, several thoughts have come to mind to how to manage these patients, right? When we do surgery, we tend to leave a lot of small fibroids behind, fibroids that we can't get out. And I would tell you that in my fibroid clinic, about a quarter to a third of my patients that I see are patients who had prior myomectomies, Black women, who then come in and now have what they've been told is a recurrence of fibroids, but in essence, it's a persistence of fibroids. Their fibroids that were small have now aggressively grown to a point where it's become symptomatic again. And for any surgeon, going in and doing a second or a third myomectomy is much more difficult. So when I think of the grand scheme and what the question that you posed initially is, what patients would I recommend this for? Understanding my concern about the lack or dearth of data on infertile patients, I think Dr. Jordan brought up a good scenario, right? The FIGO 0s and 1s and the 2s where they're large and hysteroscopically, I'm looking at a difficult surgery or maybe a 2 or 3 step procedure. I love that idea of being able to maybe shrink that fibroid or to help it enucleate where I'm not encroaching on the myometrium as much with my resectoscope. I think in some patients where I do a myomectomy and I see these small fibroids where I know I'm not going to be able to get out, being able to maybe follow up with a HIFU to get these small fibroids, like Dr. Rodriguez said, and maybe reduce the recurrence or persistence, I should say, of these fibroids would be very, very enticing to me because I don't want to see these patients back, right? When I do surgery, my goal is to alleviate symptoms, maintain a good, healthy uterus that they can conceive and carry a pregnancy, and to keep them out of the operating room again. And it doesn't have to be all HIFU and all surgery. Maybe there's ways that we can sort of do joint procedures.
Do you ever recommend RFA for your patients, Dr. Petrosa?
Same scenario, though one of my colleagues is doing this in patients with these submucosal fibroids, where she will go in with the hysteroscopic RFA device and will do it and then come back and do a second step procedure. And she swears that these fibroids are easier to remove. There's less myometrial involvement. These fibroids are almost enucleating themselves out into the cavity. And listen, I think if that works, that's great. My only concern with our RFA is that even though there's a safe zone, I do worry that there is a component of normal myometrial damage. unlike the HIFU, right? I think there's just more risk associated with it.
Very helpful. And Dr. Petrosa, do you counsel patients to consider HIFU, or what is your?
It's we have limited availability for HIFU in our region, believe it or not. And last I heard it's not typically reimbursed, and so there's very limited opportunity that I'm aware of for having patients consider HIFU.
Got it. How about you, Dr. Jordan? Are you primarily doing HIFU, or also more broadly as a gynecologic surgeon doing myomectomies, et cetera?
I think we're doing everything. We have medical therapy, embolization, HIFU, and myself. I'm also doing surgery. So I think that the idea is to try to find, there is no like the best treatment option for fibroid. I think patients are individual, fibroids are individual, and the holy grail would be to find the best option for that individual patient and symptoms and fibroids, and that's the challenge.
You're able to offer all these different options to your patients.
Yeah.
Your colleagues that maybe don't do HIFU, do they refer to you specifically to talk about this?
Yes, yeah. So we are the only center here in Finland, and actually only active center in Scandinavia performing HIFU. So we get referrals from all over Finland and even some from other Scandinavian countries as well.
Dr. Peggy, perhaps I could comment a bit on the vascular fibroids. Now, vascular fibroids, as what all the other speakers have said, if they are for infertility, I think I will err to do the surgery as opposed to HIFU. But there are some patients who are insistent on non-invasive surgery, or patients who are not trying to get pregnant who have vascular fibroids. We have learned how to do things that what Dr. Jody was saying. One thing we do is ethanol injection. We call it percutaneous ethanol injection into these vascular fibroids prior to doing HIFU. That actually sensitizes the fibroid, and you can actually get good ablation for vascular fibroids. This is one thing that we do. Some people use another product called, I've written it down, lauromonogol. It is actually a sclerosing agent that can be injected into the fibroid, and then you do HIFU. These are for vascular fibroids. And the other one is actually what Dr. Jody said, is to use Sonozoid. Sonozoid is actually a microbubble that stays in the body for about 3 hours. So we use the microbubble to cavitate the fibroid. So we can do the HIFU at a lower wattage. At usually the watts that we use, the highest is 400 watts, but here we can go down to 200, 250 watts, and we can do cavitation. And this is also very useful for patients who have vascular fibroids. So these are things that I just learned this about 7 months ago, and I started using it, and it is showing good results. The other thing that what Dr. Petrosa correctly pointed out are patients who have previous myomectomies. I get a lot of patients with previous myomectomies who couldn't get pregnant, and then they have multiple fibroids. And these are ideal candidates to do HIFU, because going in again is a major disaster. It's going to be a difficult surgery, and there is also a risk of hysterectomy. So these are very good candidates to do HIFU as a good method to help them to get pregnant. So I will never hesitate to do HIFU for this group of patients.
There's a question from the audience with regard to the treatment of patients at higher risk, like those with hereditary syndromes, where there's a risk of leiomyoma and renal cell carcinoma, for example. Is there a value to treating those patients early in the process? Dr. Petrosa, what do you think about that as a subset?
What an interesting question. You know, we presented a case report with a great sort of summary of these hereditary disorders that Jim Seeger had sort of put together. And we're actually, if there is a benefit to doing laparoscopic myomectomies, that we're picking up people with these hereditary syndromes based on their pathology. right? So we can see differential staining that will show fumarate hydratase deficiency, and then we can pick up the mutation. You lose that ability when you do these non-invasive techniques. But the phenotype of these disorders is kind of unique. For example, with hereditary leiomyomatosis, we're seeing that these fibroids tend to grow more rapidly, and they tend to recur a little bit more frequently. And when I say recur, actually, I mean recur. I mean new fibroids that come out of nowhere. And so I think they still would be responsive to a HIFU procedure. I think they just, like a lot of our patients, will just need a little bit closer surveillance looking for a recurrence of the lesions.
Very helpful. We have a few minutes left. Dr. Selva, any remaining questions for the audience and for the panelists?
I think you have covered most of the topics that we require. I think Dr. Petrozo and Dr. Jonathan have mentioned that you are not actually in big favor of doing HIFU for patients who are thinking of pregnancy or infertility patients. Your choice will be more of a surgery, whereas Dr. Jordi is for HIFU for this group of patients, irrespective of what the age is. Am I right to say that?
Yes, I would agree. And simply because we just I don't have the data to sort of convincingly tell my patients that this is a safe procedure to do for them.
So
but the surgery is a safe procedure for them?
I think it depends on the skill set, right? So I do.
No, because you can conclude the surgery, remove the fibroid completely, but the aggressive of the surgery is clear.
Let me remove the word safe. I think the data that I have on implantation and being able to conceive and not impacting their ability to conceive is a little more known with the surgical approach than the non-surgical approach. And that is what my patients are seeking, right? I have data on myomectomies and implantation. I have data on pregnancies. I have data on live births. I have data on placentation, right? But it's that early piece, the implantation, that we don't have any data on, right? We say, oh, we have pregnancies, therefore the ability to conceive is not compromised. We can't say that. And so until we have that data and we have that denominator and we look at it in a scientific way, it's hard for me to tell my patients, go ahead and do it. And when I speak about this, at least in my mind, it's the intramural fibroids. It's the 503s and 5s, right? I think, like Dr. Jorgensen said, for something where it's in the cavity and you're just trying to make a surgical procedure easier, I think that's a different group. But we just don't have that data. And I would love to have it. I would love to be able to tell my patients, HIFU is for you. Not being able to do laparoscopy. As I get older, doing laparoscopic myomectomy is tougher and tougher for me. I feel like someone hit me with a 2x4 at the end of my surgical day because it is taxing on the surgeon's body. I would love to be able to say to do HIFU. But right now, I just don't have that data.
What I think is very difficult to have data on this topic on different treatments. Not only HIFU. I'm of course. The first thing I have said is of course there is not enough data about HIFU and this topic. But for me, the other treatments is similar, and the Cochrane review is concluded is similar. Is it okay with you are sure that the surgery, myomectomy, especially patients including patients during myomectomy, you enter into the cavity, you don't have problems in these cases? It's very difficult to conclude that it doesn't provoke any problems in the cavity of these patients because the inflammation is normal after any surgery, whatever surgery we done. And for me, the surgery is perfect. I'm a surgeon. Yeah. I'm a gynecologic surgeon, of course, and I operate patients with benign pathology. I'm a specialist in endometrial cancer, ovarian cancer, and of course, myomectomy, But finally, I have concerns about this problem of the surgery in the uterus, because all we know that the surgery provoke other adhesions, inflammation, and in the uterine cavity there are some evidence of the adhesions after laparoscopic myomectomy, in the open, and of course in the open myomectomy, and for sure it could be a problem for this patient. Of course, we remove the fibroid, of course, but we provoke another problem. For me, it's clear, but of course, in the HIFU is a disruptive technology, and of course, for me, the first is the patient. I speak with my patients, and I speak about the positive and negatives of surgery, HIFU, radiofrequency ablation. I do this treatment also, but finally the patient decide. Oh, of course, you have a treatment with less morbidity, with mild postoperative pain, procedure under constant sedation, outpatient procedure, faster recovery, no skin or uterine scars.
Dr. Rodriguez, I can see Suzanne going on. And I totally agree with you. Once again, there are risks with surgery that I think all surgeons would wish to avoid. I think it's difficult for me. My patients, I can tell them based on the data we have in HIFU, if you get pregnant, I can feel pretty confident that you're going to have a normal pregnancy. But my patients who are struggling with infertility are asking me, will it impact my ability to conceive? And I can't give them that information yet. And that's what these patients want. Getting pregnant is only half the battle, right? Or being pregnant is half the battle. They want to know, is it going to disrupt their ability to get pregnant? And it's difficult for me to have that shared decision-making unless I have that data. Right?
I'm going to stop you right there, Dr. Petroska. I think it's a great stopping point. I really want to thank the panelists for a very interesting conversation. And what I think it's done is it's really kind of spelled out for the folks that want to push this forward what kind of work we need to do. We need to marry the champions like Dr. Rodriguez and Dr. Jordan with Dr. Petrosa coming up with rigorously designed studies. And I'm sure I'm speaking to the choir here. Dr. Boomsa is going to echo this as well. Rigorous data to satisfy Dr. Petrosa, but carefully designed studies as well. We don't want to have studies we can't recruit to. And I think some preliminary data is out there. People have looked hysteroscopically after focused ultrasound and talked about lack of adhesions and so forth. But that's a single case study. We need to have larger studies looking at this, looking at the implantation factors you mentioned. But it's really spelled out for us what we need to do next. On behalf of Dr. Selva and myself, I want to thank the panelists again and the audience, and we'll move on to the next session now.
Thank you, Hedgie and Selva, for moderating that, and the panelists. It was great to hear the perspectives of a surgeon like Dr. Pedrosa, who doesn't do focused ultrasound, to Dr. Rodriguez, who likes to do ultrasound, and then Dr. Jordan, who's right in the middle. That was a fascinating conversation. Before we proceed to the next session, though, I would like to, if possible, if Dr. Evie Stewart could come on for a second and give us our perspective, because she's published a lot of papers on patient perspectives and patient preferences on how to choose a treatment option and how much to involve them. So based on that discussion, Dr. Stewart, how would you counsel a patient who seeks fertility and wants to choose between one of these treatment options?
Yeah, so I think it is a complicated process, and different individuals weigh different facets in different ways. That I think that we don't have good data for a lot of things in gynecology. That again, myomectomy has been grandfathered in as the standard of care. And I think although we don't have complete data, that the safety data that I see suggests that for pregnancy, focused ultrasound gives equivalent benefits. At least in my clinical experience, the people who go the focused ultrasound route with a desire for pregnancy tend to be very sophisticated and self-motivated. They've read the literature, they've decided this is what they want, and often they've fought their way through multiple layers of barriers to get there. And so I think that I would love to have randomized controlled trials of focused ultrasound versus other therapies, but I can tell you I've done one, and we found patients who were trying multiple ways to subvert the randomization, including going from one site where they were randomized to the traditional therapy to a second site to try to get what they wanted. And so I think that at least for this issue, registries, adjunctive studies looking at markers of implantation are probably going to be more likely to be successful, at least in the US. Outside the US, you may have better opportunities where access is limited, but I think where the marketplace pays for you to be able to have these options, it's going to be hard to really get randomized data on this question.
Thank you. Thank you. Thank you so much. Okay, on to our last session. I'm really proud of everyone for hanging in there. I know it's been a lot, but the conversations have been fascinating, and each session itself could be a whole day workshop. So let's go on to the last session. It's going to be moderated by, again, Dr. Ganouni and Dr. Jing. So I'll let you guys take it from here. Thank you for putting the slide up.
All right. So again, it's my pleasure to convene this panel looking at burning question 4, how can we enhance commercialization of a HIFU machine for fibroids, and what regulatory and reimbursement issues need to be addressed? So this is going to be about a month-long session in which we address this this topic and hopefully arrive at a conclusion. This is going to be a real challenge, obviously. This is a big question. It's my pleasure, though, to introduce Dr. Jessica Foley, who was a managing director and chief scientific officer for the Focused Ultrasound Foundation, where she oversaw scientific programs and especially worked with governmental policymakers and regulatory agencies as an advocate for the community. She's now vice president of product strategy for Profound, where she leads the commercialization strategy for the Sonolive focused ultrasound system. Dr. Stewart, as we all know, professor of obstetrics and gynecology at Mayo. In particular, she's mentioned some of the studies that she's piloted and pioneered, currently leading the collaboration for equity in uterine leiomyomas, specialized center for uterine fibroids, and co-leading a project on ascertaining long-term outcomes for fibroid treatments. Just an incredible voice to have with us today. Dr. Muravata from the US FDA has worked in ultrasound metrology modeling for 20 years, now assistant director for the Division of Applied Mechanics in OSL at the Office of Science and Engineering at the FDA's CDRH, the Center for Devices and Radiologic Health. It's my pleasure to have you guys here to talk with us today. I wanted to briefly introduce some of this topic. We're going to try to think a little bit about strategizing about how FUS can become an integral tool in our toolbox for treating patients suffering from fibroids. Dr. Singh, by the way, anytime you want to jump in, please. Well. Thank you so much for co-moderating this with me. Your expertise and background is going to be invaluable in this. My experience is limited to the US, so I'm going to talk a little bit here about US codes. But I'd love to hear all the experience from US and Europe and Asia as well. But if we look at our history in CPT codes, we started off with this 0071 and 72T code that we know, which is for treating uterine leiomyomata with MR guidance. We're still there with this T code tracking code. We have not progressed in not quite 20 years in terms of moving from that code forward. It is very difficult to get insurance authorization for this code. We've basically been doing out-of-pocket at our institution for a while now, trying to find the number where we can provide access to people without making it too burdensome. C9734 was the code for everything other than fibroids. We're typically used for bone. This came out of the randomized study of patients with bone metastases who were treated with a sham procedure versus focused ultrasound for painful bone mets. And then we've been using it since for non-bone metastases and for other applications as well. in the brain, a T code initially for treating stereotactically, but recent progress and maybe a path forward for us to think about, because now there are level 1 codes available for the brain and level 1 codes available for prostate treatment. As you can see there, 61715 and the 2 codes for prostate ablation as well. Dr. Stewart, you mentioned the challenges of recruiting for randomized studies and the effort people will go through to try to get the treatment that they want. Much to the credit of Profound, honestly, they've managed to recruit to a study that I think in Europe, in the UK in particular, they have tried again and again to randomize men to prostatectomy versus some kind of ultrasound ablation, and never really succeeded with that. Profound has succeeded in recruiting men to a surgery versus ablation approach for prostate cancer. I think it's a surprise. I would not have predicted that given the fibroid experience, but we're there now. And so, I'll move forward a little bit to say maybe there's hope. I wanted to show this information. I pulled this from a US insurance policy, from 2 policies, and I've taken out some of the identifying information. And I'm going to ask you to, at the end, maybe try to identify which of these the policy was in favor of and which of it was not in favor of. And so, for example, the data presented in the policy in one case talked about a meta-analysis that included 2 RCTs, 45 cohort studies, 19 case reports, 2 other systematic reviews. Another one talked about a systematic review that included 38 studies of 2,500 women. Another one talked about a meta-analysis, a systematic analysis of 10 studies of 589 women, showing a significant impact on symptom severity scores. Another talked about a combination of systematic data where 8 studies were included. In the pooled analysis, they saw a significant improvement in HRQ and quality of life, as well as symptom scores. And they also presented reintervention rate that was quite low. Of these systematic reviews, I believe one of them was an RCT. So of these, Dr. Stewart, I'll put you on the spot. Can you guess for me which of these is a radiofrequency ablation and which of these is focused ultrasound? I'll tell you, one of them is radiofrequency ablation. Do you know by chance which one it is would support radiofrequency?
I would say the one with the larger number of RCTs, because they've certainly been more successful at that than focused ultrasound. So
you mean this one with the 2 RCTs?
Yeah.
Okay, so that I would have guessed the same. It turned out it's this one that included 1 RCT, and it was a meta-analyses that went forward from there. I'll jump forward to say that based on these meta-analyses, they refer to Bradley and Lynn. The American College of OB-GYN produced a level B recommendation for laparoscopic radiofrequency ablation as a minimally invasive option for management of leiomyomas in women deserving uterine preservation. Although they did mention that the data is, although the device is FDA approved, the data has been studied primarily in non-randomized trials. Nonetheless, this insurance company considers treatment with laparoscopic or transcervical RFA to be medically necessary as long as uterine preservation is desired, as long as fibroids are not too big, and the uterus itself is not too big. Compare that to focused ultrasound, where ACOG states limited low-quality data suggests that FUS is associated with a reduction in leiomyoma and uterine size, but small randomized comparative trial data suggests that compared with UAE, it's associated with less improvement in symptoms and quality of life and a higher risk of reintervention. And this insurance company, as most of the private insurance companies in the US, maybe all, say it's not considered medically necessary, it's investigational. And they go on to say that well-designed clinical studies evaluating the safety and efficacy using relevant outcome measures are lacking. Studies have lacked comparison to current standard treatments, the current data does not follow patients beyond 3 to 5 years, or up to 3 to 5 years to provide longer follow-up. And basically they're asking for well-designed RCTs with sufficient follow-up periods and appropriate outcome measures. So a good follow-on from what we were just talking about. I will add this as well as a potential wild card in all of this, and maybe You can maybe speak to this, Dr. Stewart, to some extent as well. I don't know how much this has an impact, but these are RVUs associated with hysterectomy, laparoscopic myomectomy, and RFA. And all of them have fairly generous RVU totals, fairly similar RVU totals. This source indicated the transcervical is less. I don't know how much RVUs drive things as well, and how that might impact how people decide what to offer patients and so forth. But that's potentially another reality for us to consider here. So I'll exit there, and let's go back to the main screen here, and let's start with that. Dr. Singh, do you want to start with some questions for the panelists, please?
Yes, please. Sorry, bear for my voice because I lost my voice. Okay, so actually, Peggy has mentioned about on the regulatory side, because I actually want to bring the topic to commercialization, which I think is important. Okay, because especially after listening to the whole session, we talk about doing more effective studies, optimizations, and all these. If we don't even have accessibility to this technology, all what we talk about is will be still trapped in academic centers. Okay, so, and by talking about the commercialization, and actually I want to take this moment for, although we're talking about fibroids, but for all of us actually to reflect. We have more than 171 indications about the HIFU technology in different stages of clinical development. But the first indication that received the US FDA approval, fibroids, are still on its way to be commercialized. So I think it's the moment for us to collectively think, okay, how can we work together to actually work on this bottleneck? Okay, so, but when we talk about the commercialization, okay, I think at least we need to be clear. Why do we need to want to be commercialized? It's not about business. This technology, for this technology to lift the ground and get access to the patients and to the doctors, we first need to do good medicine. Okay, so good medicine warrants a good business down the road. Okay, Chongqing HIFU has set up about 340 centers worldwide. Okay, 60 centers outside China and 370 centers within China. And by the way, almost all of them are commercialized centers. So if there's any experience in the whole field, I think Chongqing HIFU has on its way to achieve partial commercialization, especially in the field of women's health, means fibroids and adenomyosis. Okay, so if based on the experience I want to share with the panel is that I think we need to, whether it's a fibroid, commercialization of a HIFU technology requires a strategic approach and addressing market adoption, regulatory hurdles, and the reimbursement challenges. Okay, so it's not just about to get a PCT code. It's not just about the conduct pivotal studies. Okay, and it's we need to define the pathway of commercialization and work together to put all the resources together to get down to overcome this bottleneck. Okay, and another thing is that commercialization of a technology is beyond just good medicine. It involves policy making. It involves regulatory approval. Okay, and let's don't forget, it involves patients. So if we think about the studies we have conducted, how many of them actually are patient-oriented studies. Okay, especially and in this era of information era, I think patients are more entitled to know the technology. So market adoption involves not just the doctors, the hospitals, but involves the patients as well. Okay, so actually, I would ask because I think Professor Elizabeth Stewart is among the very first to lead the efforts for the US FDA approval. And so actually, I want to get Dr. Stewart's perspective on the market adoption. Means how do we, do you think energizing the patient education is important? And how should we do it? And especially, we have a foundation. How can we devote some resources and also the associations, okay, towards patient education?
Yeah. So I think patient invigoration is important for a couple of reasons. I think first of all, even the patients that I see that tend to go in the direction of focused ultrasound have been self-directed. I will talk to my patients about it, but I find by the time they get to my office, they have a good sense of that I'm heading in the direction of focused ultrasound or I'm heading in the direction of surgery. The second thing is I look back at the experience with uterine artery embolization, that I was a clinician in the era when UAE was just starting to develop. There were a lot of insurance barriers. There was onerous pre-authorizations that you had to go through. And I think UAE somehow had two things that focused ultrasound hasn't yet. And one was demand, that, after you go from sending one pre-authorization a month to one a week to several a day to the insurance companies, then there seems to be less interest in having you fill out all of that paperwork. I think the second thing is UAE seemed to have coding that they could use that was less onerous, so they could do it as a more generic procedure and get reimbursed for it. But I think, as with many things in medicine, if the patient demand is not there, the system will put up a barrier.
Thank you. Thank you, Dr. Stewart. Another thing about the regulatory considerations, approvals, okay? And so with our experience of bring this technology to the global scheme, okay, actually leading US FDA approval is probably the hallmark a lot of markets, a lot of countries, markets are looking for for these indicators, okay? And because this is one thing. Second is that if you look at when you bring this technology to developing countries, a lot of these countries don't have the infrastructure, clinical research infrastructure to do the studies necessary to inform the respective professionals in that country that this technology actually is good to be adopted. Okay, and as a result, the policymakers also lacks the information from their own country. Okay, to make the decision to include in their national reimbursement plan. Okay, so therefore, how by the US FDA directed the clinical research. Okay, and the bar is very high. Okay.
Dr. Singh, if you don't mind, I'm going to ask a question of
yes. Okay.
Jessica and Dr. Stewart, or Dr. Foley and Dr. Stewart. We've known each other too long, Jessica. I wanted to ask a question specific to ACOG and get your perspectives on this. I will point out that essential tremor, the treatment of essential tremor was not done via a randomized controlled trial in which people got or didn't get the treatment. And yet it is covered by Medicare and covered by private insurances throughout the country. So there's a different standard being set here that, it's going to be a challenge to meet, obviously. But one of the things that did happen on the neurosurgical side is the neurosurgical societies drove demand. So you talked about patient demand, Dr. Stewart. That's one aspect of it. But a big aspect of it is the surgeons themselves saying, we want this. We want to be able to offer this to our patients. And that, I've been fortunate to work with gynecologists at Stanford that had equipoise about the different options, and we're always willing to consider focused ultrasound. But that I don't know how common that is. Maybe at Mayo and other special tertiary centers where you get to work with Dr. Hesley and people like her, that's possible. But I'd like to get your opinions. How do we get ACOG to support this as they have supported RFA?
I think it's going to be a challenge. I think ACOG is a organization of OBGYNs, and because focused ultrasound surgery in most places is outside of the primary control of OBGYNs, they're not going to be as much of an advocate as a surgical procedure that their members perform. I think in general, ACOG also tends to be fairly conservative. That's an issue. But I think also if you look at innovation in a lot of medical fields, innovation tends to come last for women. Again, there are multiple potential reasons for that. And again, is it protecting safety for pregnancy, or is it more of a misogynistic role? I think we could have a whole session on that, but I'd be interested to see what Jessica has as an outsider perspective on ACOG advocacy.
Yeah, so I don't have any specific insight into ACOG, but just sort of looking at the differences, I think, between what historically we faced in focused ultrasound adoption for fibroids versus, say, as you were mentioning, Peggy, something like tremor. Fibroids there's many other treatments, as we've discussed today, and treatments that gynecologists would view as pretty good treatments for their patients. On the tremor side, you basically had drugs and they weren't working. If they weren't working, you had DBS, or then you had focused ultrasound. And then when you talk about patient demand, that really became something that the patient demand was sort of off the charts when focused ultrasound came on the scene. So I think that there are just some inherent challenges in fibroids being a disease that there are many other treatments for. And so that can be, when we look at all the different focused ultrasound treatments, that can make it more difficult in terms of coming into a crowded landscape like that. And I do think that obviously the women's health and maybe a less of a or differing view on women's health versus, say, men's health is factoring into that as well. But I think that's why it's really important for us to kind of start at where the challenges are. And we know that even when focused ultrasound was commercially available, many, many years ago and first got FDA approval, the utilization was never there. And so looking at where those problems were, is it the gynecologists who didn't want to do the treatment themselves or refer to radiologists? Is it that sort of, lack of a better term, turf battle between different specialties? Is it the awareness level from the clinical community, the lack of data? I mean, obviously, we're in a different stage now than we were 20 years ago in terms of the data that's there. But really, that's what I think is important about this discussion we've had today, is assessing where are the data gaps. So really being able to identify those with the clinical community to determine, what would it really take for you to treat? Or maybe there are just many of them that wouldn't. They're just not going to, they're not going to refer to a treatment like this. So I think, to me, that's a big part of it. And then looking at the experiences that these other quote unquote alternative treatments for fibroids have had. Dr. Stewart mentioned the UAE and maybe why they were successful at the beginning. Is it the patient demand? Is it this generic coding? I mean, kind of looking at what the coding situation is right now with focused ultrasound, Peggy, you laid out, it's very different. I mean, there are several different codes. Is it possible now for focused ultrasound treatments, new focused ultrasound treatments, to latch on to a more favorable code there? Is it hurting us that there's a fibroid code or something like it that still exists? Is that somehow kind of poisoning the well as we move forward with new focused ultrasound procedures? So I think there's really a very complex landscape of challenges, and it's really for us to identify what's creating the biggest hurdle. And then hopefully, if it's from the clinical community, ACOG will get on board eventually, but maybe there's other ways around it as well.
Just to go back to neurosurgery for a second, I mean, the DBS is a very effective treatment for tremor, maybe underutilized for essential tremor, but obviously used commonly for Parkinson's disease when it becomes severe enough. So, there are alternatives for fibroids. There's alternatives for prostate, and yet things are moving forward there. But one difference, and that touches on what Dr. Stewart said as well, the neurosurgeons do, in most places, the neurosurgeons primarily do the brain-focused ultrasound procedure, whereas in most places, the OB-GYNs have maybe a role as a referring physician for fibroid procedures. So if there was a way to get a device in an OB-GYN's office that he or she could use on a patient, much the way they do, a diagnostic ultrasound or something like that, one could imagine a very different response from that clinician group, I think.
Peggy, may I add a comment to that? Okay, so actually, I want to share is that because Chongqing HIFU is ultrasound-guided HIFU, so when we introduce to women's health, we focus on women's health and the fibroids, and then brought to the adenomyosis. So because we focus on women's health, and so we introduce the technology actually to the OB-GYNs. Okay, so the idea is this is a non-invasive technology. It's up to them to integrate that into their service, okay, depending on their skill of sets and also depending on the patient selections. So therefore, it's there to help them. So you hear from doctors from using Chongqing HIFU technology today, they are all OB-GYNs. Okay, so when we go into any given country to open the market, we usually work with 3 societies on the women's health side. One is the OB-GYN Society of that country. One is the minimally invasive surgery of the OB-GYN field, and then the Fertility Society. Okay, so, and this is one thing. Second is that since it's ultrasound-guided HIFU, does not require, it only requires sedation. No generalized general anesthesia is required. And also for the installation, it doesn't need to be in the hospital setting. So for commercialization, actually, in South Korea, we have 21 centers. It can be set up in a variety of settings in the hands of the specialists, okay? But it's not limited to just the specialists of that field. We also train interventional radiologists, okay? Actually, any doctors who are familiar, if it's outside the specialty field, who can, who is good at the imaging, can also learn that as well. So introduce the technology, put this powerful technology in the hands of the specialists who takes care of the patients. It's very important. And that's our experience.
Dr. Stewart, what do you think about that? Do you think gynecologists, there were some gynecologists that adopted this technology themselves at the beginning. Do you think that they'd be open to another round of this with a new device, something that doesn't have to be in a hospital setting, like FUS doesn't need much in the way of sedation or maybe mild sedation for treatment?
I don't know that even with MR-guided focused ultrasound, shortly after the FDA approval, there were centers that were outpatient centers headed by gynecologists, but those are no longer standing. So I think that it would, improve adoption within the OBGYN community to have focused ultrasound in the hand of OBGYNs. But it's a very different skill set than what OBGYNs are using at this time. So is it, is the learning curve so steep that that's not worth doing? But again, if you look at the growth and proliferation of the minimally invasive gynecology services, that didn't exist when I started training, and they started with hysteroscopy and laparoscopy and went to robotics and now do radiofrequency ablation. So the skill set of those providers, I think, could accommodate learning focused ultrasound, but it's a multifactorial problem, and you have to have patient demand, you have to have provider acceptance, and you need access. And for some reason, all of those things didn't come together for focused ultrasound with FDA approval.
How much do you think the MR was the barrier? What if you had to put a percentage on those various factors that you mentioned? How much do you think that MR guidance was a barrier to adoption, Dr. Stewart, in your opinion? Was that a major factor, or?
I think it was a significant factor. I think, again, that gynecologists were really the innovators of ultrasound in many ways, that, using it for OB, and even back when you were doing the B modes, there were, private practices in OBGYN that had ultrasound machines in their offices. So I think the knowledge base is an issue, but potentially also the financial barrier may be an issue. That these days you can get an ultrasound machine that works on your iPad. It may not be sufficient for doing procedures, but the cost of ultrasound is much more affordable than the cost of a magnet.
Dr. Elizabeth, actually, I just want to answer one of your questions you just brought up. It's about the learning curve. Okay, because that's a sick. So actually, on the pathway to commercialization, it's very important to develop the international training program as any of the technology. Okay, so on the ultrasound-guided HIFU, by working with the professional societies of the field, like the OB-GYN field, and also there's the International Society of Minimally Invasive and Non-Invasive Medicine. Okay, so we work with the professional societies. We have developed the international training program. And through the 20-center studies, we use the Oxford ideal framework of clinical trial. And in that trial, we built in the assessment of the learning curve, because this is a surgical procedure. You have to teach the doctors. It's not a pill. So doctors then provide it to the patients. Therefore, if any clinical study does not have the component of assessing the proficiency of the doctors, that study itself actually has a problem. Okay, so from our in real world experience, and also by executing the training program, now we know the learning curve for the OB-GYN is pretty well, okay, which is between 20 cases to 40 cases. And we have developed so we have in China 21 bases, international training bases that can accept doctors, okay, so that they can complete at least half of their learning curves on Chinese patients, okay. So I think that this is the thing, and also the joint certification, okay, it's also it's important. So developing a robust international accredited training program is very important. And we are on that path.
Thank you, Dr. Singh. Dr. Foley, you had your hand up?
Yeah, I think just, when we were talking earlier in the panel about innovation and ways that we can improve the, treatment planning, the treatment monitoring, all of that with AI or other algorithm ways of doing that, all of that could improve the physician experience, could improve the training aspect of it and the learning curve, reduce the learning curve. Also the workflow challenges that were really prominent in the early days where this was taking, 3 to 5 hours or more than that. And even then you weren't even able to treat much of the fibroid. I just really wonder how much of the challenges we face in the US is because the early days, were so different than they are now. And, you can only treat 30% of the fibroid, then 50, then finally 100%. It took forever to do. Obviously, technology has evolved, not just AI, but the hardware technology of these systems. All of these systems are much better than they were before. And if that sort of just, is a bias that a lot of gynecologists that may even know what this technology is, they're kind of biased by that early days. And if we kind of reinvigorated this field now with new technology that's more optimized, workflow that's more optimized, we could kind of grow the field back up again. And now we would also have several alternatives, potentially several different devices that we could offer for patients as well.
Yeah, I agree that that's part of it, but I think there is something about patients and acceptability of fibroid therapies that, given that we have 2 FDA-approved drugs for fibroids, and they're not being widely adopted, that also makes me think that there's something underlying that isn't just, was the technology rolled out correctly? So again, because the drugs became available in 2020 and 2021, my original impression was, people don't know the data because this is a pandemic and they're not reading, journals, but we still haven't moved in that direction. And is it a patient level barrier that when they're told they have a fibroid tumor, that there's some still reservation that a tumor means malignancy and that surgery is the way to dispel that? Is it the invasiveness of some of the approaches that makes it seem more effective? Is it that by the time they finally get to a doctor who's available and open, that they've got a different mindset than if they had been approached when they first had symptoms? So that's one of the reasons this co-equal project is important. It's really trying to understand what the barriers are for women, because they're either not hearing about all of their options or they don't really see the full array as being available to them or for them.
That's fascinating. I didn't realize that the medications were also under-adopted or underutilized. That's very interesting. Let me ask a slightly, hopefully controversial question at the end here. So challenges because fibroids have a lot of other good options, some of which seem to still be underutilized, as I just learned, but still a lot of options out there. The docs aren't as familiar with them. Chungking HIFU spends a lot of time and effort to train folks and bring them up to speed and make them comfortable and knowledgeable so that when they talk to their patients, they know the ins and outs of HIFU as well as they know the ins and outs of surgery and so forth. What if what we were talking about was adenomyosis? where the gynecologists don't necessarily have a good option other than a hysterectomy or medications, right? And it's one or the other. There's, either remove, there's not uterine sparing, or you can't use the uterus because you've got to take hormonal medications. Do you think that would make the focused ultrasound challenges less of an issue and adoption higher, make gynecologists more comfortable to refer with something that maybe they're not the MR physicists and so forth, or the ultrasound physicists, but hey, here's something that might work for you short of me taking the uterus out? What do you think about that, Dr. Stewart?
Well, I think anytime you put a new hammer into a gynecologist's hand, that they'll use it. So I think that adenomyosis does have that advantage, but I think there's still a knowledge barrier, because I think in the gynecology community, there's still a widespread belief that adenomyosis is only a disease of women in their late 40s, and isn't seen in the younger patients that I see with implantation failure or infertility. So I think there would still be a learning curve to educate people about a contemporary understanding of adenomyosis. But I think it is an innovative thought that if you can't treat adenomyosis in any other way except hysterectomy, and you will have a subset of your population that will decline hysterectomy, that might be an innovative tool. And in fact, some of the earliest treatments were adenomyomas, which were thought to be fibroids until there was central review. So there's definitely experience there.
Yeah. Dr. Singh, what's the experience been with adenomyosis? Have you found that that's been a popular application?
Yes, a very good question. Actually, first, we already in real world have from the minimally invasive surgeons, OB-GYN minimally invasive surgeons, that they themselves, once they knew the HIFU technology, they recognize adenomyosis compared with fibroids requires put this way, HIFU technology has more advantages in treating adenomyosis compared with laparoscopic surgery and other approaches. Second is adenomyosis affects fertility more in a way and also the quality of life of patients more than fibroids. Okay, so they are limited. Therefore, by giving an option in the hands of the OB-GYN, they are more acceptable of looking at take the opportunity to look at HIFU. Okay, and once they started with adenomyosis, then they say, oh, let's look at fibroids. Actually start to look at the big fibroids, multiple fibroids that affect fertility. Okay, and they say, oh, this we cannot do. Okay, so let's look at so then they take a closer look at how can this help them to handle fibroids. Okay, and after they achieve that, they will say, okay, let's look at the 5 centimeter, 8 centimeter, whether that will be as good as the laparoscopic surgery. Okay, so we've been working with ESG and APAGE, so in 2 years ago, in the annual meeting of ESG, European Society of Endoscopy and of OB-GYN, the founding president, Professor Rudy Leon de Wilde, okay, in the keynotes addressing 2,500 OB-GYN minimally invasive surgeons, and said, if there's any indication, we should think about a non-invasive approach other than medication, is adenomyosis for the sake of patients. And now there's a new technology there called HIFU. Okay, so this is one thing I want to add on. So another thing is that I think it's important to engage FIGO because they deal with the women's health, not just a technology per se, but looking at women's health. Okay, so therefore, for fibroids, I'm very happy to share with the panel that Professor Philippe Dagan, the former vice president, has led a committee of developing the expert consensus of fibroid, not about HIFU, about fibroid. And I think Dr. Elizabeth Stewart also worked on the chapter of HIFU. So in no later than this October, in the FIGO meeting, the expert consensus will be released, and the HIFU, both MRI-guided and ultrasound-guided for the treatment of fibroids, will be included in the expert consensus. I think this will play a major role for the global doctor sensitization. Okay, so for the, because this is a FIGO expert consensus. So working with FIGO is important. So down the road, adenomyosis, I think that's another good indication to work with FIGO on generating the expert consensus or the guidelines.
That's fantastic. And Jessica, how does that impact you at Profound, you think, hearing that? Fibroids versus adenomyosis, is it either or, you both? What do you?
I mean, it's very interesting, perspectives, and I think, I think it particularly, as Rosie just mentioned, that some physicians are introduced to the technology via adenomyosis, and then it kind of opens their eyes to fibroids. That's a very interesting perspective to hear that as well. So I think, yeah, it's definitely something to consider, and maybe we need another workshop on adenomyosis.
Yeah. And also the fertility, preservation of fertility, especially for women who has the fertility design and already on the IVF track. Okay, I think that's another point which united doctors' needs and the patients' needs together. So I think we need to strategize how, when we introduce the technology, what is the entry point. But the fibroid is the learning curve for this technology, for doctors to learn. This is the learning curve.
Well, it's 9 o'clock, just after 9 o'clock, and it's very interesting to the difference in a way between this session and the last one. We were very focused on data and biological factors that might impact implantation and how to generate those kind of rigorous results. But as Dr. Boomsma mentioned in the comments, and as others have mentioned as well, it's multifactorial. This education of gynecologists, access. Several of the folks that were commenting from the gynecology side said, I don't have anywhere to send patients to get this done. So it's the question is kind of moot, whether you're going to refer or not, or whether you're open to it. There's nowhere for them to go. And, I think Dr. Stewart mentioned as well, demand, having patient demand, physician demand, changing the insurance company perspectives, even in the absence of RCTs, as others pointed out. UAE got there without RCTs, as I mentioned, brain procedures without RCTs. So there's definitely going to take a lot of angles to get at this. But I think another thing to acknowledge here, several folks have mentioned the inequity in access, right? And the unfairness of this, right? That we have these minimally invasive tools available for women. They work well. And the fact that they're not readily available is unacceptable. So I think that needs to be kept in mind and motivate all of us.
Thank you.
Well said, Peggy.
Absolutely, yeah.
We summarized our last session very well. Thank you to Rosie and Peggy for moderating it, and to all the panelists for your candor in really helping to identify the barriers and where we need to work to move this forward. So thank you all really for taking the time to join us for this very productive and inspiring exchange. We hope this will serve as a catalyst. I already have an idea for so many working groups that you all have proposed to enhance the clinical adoption of focused ultrasound as a safe, effective, and non-invasive treatment option. Just so you know, a link to this recording will be available on our YouTube channel tomorrow, and it will also be sent to you directly through an email that will go out in about a day. We're also going to construct a white paper, as Suba said, which will hopefully be instrumental in helping everyone move the field forward. I want to personally thank the steering committee, as well as Dr. Stewart, for their time and efforts in preparing this workshop. A special shout out to Dr. Noren, who has done an exceptional amount of work in organizing this workshop and preparing the tables in the program book. At the FUS Foundation, there were so many people involved in making sure this was a success. So thank you to all of you, especially Jenna Barazzi, Joe Rice, Michelle, Margarine, and the CMG staff. It is always a pleasure and privilege to work with so many professionals who work constantly on a day-to-day basis to make sure the FUS Foundation is a critical organization in advancing the field of focused ultrasound. If you have any questions, please reach out to me. My email is sleblanc@fusfoundation.org. I think you all know how to get in touch with me. And again, thank you for taking the time out of your day, night, etc., to attend this important event. And we will take on all of your suggestions and comments and help move the field forward. So thank you all.